Internal medicine linked to neurology. Kindly switch off your mobiles. Mobiles in silent mode, please. Respected doctors, Chief Faculty Dr. K. Srinivasan sir, on behalf of the API Tuticorin branch and the organizing committee, we welcome you all for this session, for this inauguration of the annual conclave Internal Medicine linked to Neurology, organized by the Tuticorin branch of API. We request our chief guest now, Professor K. Srinivasan, to come to the dais. Dr. Selvaraj, if you could please lead him to the dais. Please. Next, our National President API, Dr. Arul Raj, will please come to the dais. We next call on our Tuticorin API branch chairman, Dr. D. Selvaraj, to come to the dais. Secretary, Dr. Rajan, please come to the dais. Thank you, all of you on the dais. Before we start the inauguration, it is customary for the API National President to don the presidential collar. I request Dr. K. Srinivasan to don Dr. Arul Raj with the presidential collar of the National President of API. We now have the physician's prayer to be read by Dr. Aarti.
Physician's Prayer. Dear Lord, thou great physician, I kneel before thee, since every good and perfect gift must come from thee. I pray, give skill to my hand, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child I may rely on thee. Thank you. Thank you.
We now request the chairman Tuticorin API branch, Dr. Selvaraj, to give his welcome address.
Good morning to all. I wholeheartedly welcome the giant in neurology, Dr. K. Srinivasan, pleasantly called as KS, from Madurai. At the age of 86, at the age of 92, he is untired of teaching, especially to the postgraduates and general practitioners and physicians. Actually, this program was fixed in the year 2020, January. He was about to come, but unfortunately due to Corona, we were forced to postpone the program for 1 year almost. Even now, it's not till relieved from Corona, but he said, with courage, I will come, don't worry. Then we fixed the date as 24th today. The postgraduate and the students, those who have not come, they are really, it is a loss in your life. With this, I welcome you, sir. I welcome my teacher and Professor Dr. S.S. Annamalasamy, founder of Tamil Nadu API from Madurai. Welcome you, sir. I welcome Dr. Arul Raj, patron and national president of API, who is the man behind the show. Though we are all just carrying out his instruction, we welcome you, sir. I welcome all the senior members and especially my classmate Dr. Muthukumar Sami from Madurai, who is retired professor of medicine from Madurai, and the senior members of API and general practitioners and the postgraduate students from Kanyakumari Medical College, Tuticorin Medical College, and other teachers from Medical College, and especially Dr. Mohan, API chairman from Tirunelveli, and Dr. Subramaniam, active secretary from Tirunelveli, who are all the time behind the show, starting from the printing of invitation. I once again welcome you all for this program, and be in the hall till the program is over, and enjoy the learning of neurology and art of clinical medicine from Dr. K.S. and others. Thank you, sir.
Thank you, sir. We next request a very energetic and a stalwart in the field of neurology, our chief guest, Professor K. Srinivasan, sir, formerly Professor of Neurology, Madurai, to give his chief guest address.
Good morning. It's a pleasure to be here, sitting very close anatomically to the president of the API, which is our basic, functional, and highly elegant and as well as effective organization for physicians of all of us. We are all basically physicians, and I think we should be proud to say I am a physician and less proud to say I am a specialist. I think that should be the attitude to protect the patient. We can be visible by our specialty, but will be useful as we're going to be the whole symposium. I'm sure I know every one of us will realize ultimately. It's a very important meeting, and it's like the family coming together. I think we had a wonderful time years ago where all of us considered ourselves physicians and not as specialists. And in fact, patient benefited a lot because most specialists miss other specialties because many of them are coming by a lateral entry nowadays with a adequate experience of common diseases, which will never happen if you're a physician. In fact, in Madurai, I introduced a legislation in the university that no one to take a specialization after MD General Medicine unless he has finished 3 years in medical practice. What happened was, in our country, when things go behind the scenes, influential candidates who appeared for DM neurology influenced the university and said, what 3 years Dr. K.S. meant was the 3 years of training as a neurologist and not as 3 years before neurology. And therefore, it became again damped down. But it's unless you practice in a good general government hospital, perhaps less so in a corporate hospital, you're not going to know what is not your specialty. In fact, the entire theme of the discussion is to know that what is not neurology, what is not cardiology, what is not nephrology, rather than what is nephrology or cardiology, for which we get our degrees. Most of us get our degrees for saying what is cardiology, but not what is not cardiology. In fact, when we were MD students, one of the examinations, one of the long questions was on describe the functions and anatomy of a normal heart. Many people failed. We're all very good in throwing the echocardiogram and intracardiac pressures and other things, having a diagnosis, but very little on the symptoms for which the patient came to us. I think, and then there was another big question in which many MD students failed was prescribe a diet for a cardiac patient. This sort of questions are, only as a general physician, not as a cardiologist or a neurologist. I think to protect the patient, I stress the point, to protect the patient and protect yourself as a doctor, you need to know your basics of origin of specialty, that's general medicine. I mean, that's the purpose of this. And secondly, in several decades ago, I think I was the founder president of API at Madurai, founder president. Dr. Annamalai from Chennai inaugurated. Dr. C.R. Pillai was then the API president, I am told you will remember, he is the only man amongst all of us who looks like a doctor. We all behave like a doctor, but we may not look like a doctor. Always well dressed with a pipe in his mouth and fantastically dressed, good language, good impression, taller than all the other doctors, broader than all the other doctors physically, and therefore any person will be impressed when you say he is a doctor. Ready to pay any amount of fees at his consultation room in Rutland Gate Avenue in Chennai, opposite Germany. Nobody will worry about paying any fees to him, because I think they have met the biggest doctor in Tamil Nadu. Many people from Madurai used to go to him. Appearance and language, behavior, it's like this. In his consultation room, his patients are at arm's length, like online practice nowadays. We go through the glass door. There is no glass door, and then he only takes the blood pressure. All the rest will be done by his servants and assistants, and that impresses the patient much more than an easily available doctor at the doorstep who doesn't wear a good coats and tie and so on. I think all this make up in the belief of the patient that which carries the final. WHO said 20% of the medicines all over the world, the capsules that we give to the patient do not contain the medicines. All over the world. But patients get better because our Aristotle and our law says, as a doctor, I will relieve pain and distress, I will improve the physical condition of the patient, and the last sentence is, I will not do any harm. It's there in all our promises as a doctor. So I think as long as you do no harm to the patient with your capsule, as long as he believes that capsule is a costly one given by a costly doctor, the disease disappears. And the impression, 5,000 trials, 5,000 randomized controlled trials in neurological practice, analyzed by an Italian neurologist. Last World Congress he presented it, of which 45 to 50% were placebos with good relief. I'm not talking of diabetes or hypertension where a placebo cannot give relief. I'm talking of many of the common conditions like headache or anything else. And he found the placebos, of course, had no problem, but the real drugs had only 70% belief and killed 1% of people. The placebos never harmed anything, but you give a placebo, they ask you, sir, will there be any side effect? I'm taking so many medicines. You'll say, no, occasionally somebody will have vomiting, occasionally someone will have dizziness, occasionally there may be a rash, this sort of thing. And then many people develop that because you have suggested to them, and that occupies 1% or 2%. So placebo result is from 40 it becomes reduced to 35. And therefore they found that our practice depends on our appearance, behavior, patient communication, and the belief of the patient in the doctor. And in one study I would like to quote you, 100 people in the United States published, 100 people in the United States were given acupuncture for severe headache and neuralgias. And another 100, the 100 people were given by a good acupuncture specialist who knows the meridians correctly, and the patient who believes 100% in acupuncture. And 100 people are given by a specialist who is a novice and doesn't know how to put the needle in, and by a patient who doesn't believe in any of these internal types of medicine. And the second group is again 100%, which is in between these two. Ultimately they found those who believed in the doctor, this is published, and those who believed in the doctor, and those who did know how to do the acupuncture properly. Not everybody becomes a nibunar. சக்கரை நிபுணர்னு நிறைய பேர் போட்டுக்கிறாங்க, அவங்களுக்கே சக்கரை வியாதி இருக்குன்னு தெரியாது. நிபுணருங்கிற வேர்டு misuse very often. But anyway, it's useful for practice. Now they found that those who believed in acupuncture and was given by an acupuncture specialist who knows the Chinese form of acupuncture had 60% relief or more than that. Well, all the rest did not improve at all. Now, and then they did a lumbar puncture on all these people and blood chemistry, and they found the endorphins to be very high in those who believed in the doctor and given by a good acupuncturist. So I think it is not psychological entirely. It's some medical belief and trust in a doctor based on their earlier performance. So I suppose you understand we need not only general medicine, we also need a trust of the patient on the doctor. And we conducted one of the best physicians conference in Madurai, 1965. I think Dr. Annamali Swami was there. At that time, MGR was the chief minister and Hande was the health minister. And MGR wanted to come and inaugurate it, and therefore the conference had to be postponed a few times. And then I told MGR as chief minister, because I was his personal doctor, sir, we are going to have a greater conference in Chennai with big people all over the world. We would like you to chair that session and spare our small Madurai conference. He agreed. Otherwise, we will never be able to print an invitation. That we are very bad. And 500 people attended this conference in Madurai for 5 days. On the 5th day, there were 300 people in the audience. I think you never get this nowadays, because we have split too much, and we have so many interests. Our interests also split. Medicine is become a hobby rather than a job. Now, and I got those who came to Madurai, there was Dash from Chandigarh, top endocrinologist, Chopra, P.N. Chuk from Chandigarh, a great nephrologist, and Chutani from Chandigarh, who is a top gastroenterologist, cardiologist from All India Institute. At the time, All India Institute was the best cardiologist, and Chandigarh had the best gastroenterologists. All of them came to Madurai. Then Dr. K.S. Mani, both M.K. Mani, K.S. Mani, and all the rest were in Madurai. For just a letter from me, posted by a courier. That's all. We didn't pay any amount to them. They came on their own expense with some university grants and so on. And no company sponsored us those days. And Ramsam remembers we had to go to all shops in Madurai and collect some money with Alagappan, Kajirajan and all. Kajirajan and myself spent days together in the districts to collect large amount of fees and give it to this association. Anyway, that's how we collected money. No company sponsored us. But what was important was the academic feast by all these number one pundits in our country and hematologists from Bombay, all number one. They all came for a sheer letter invitation, not for any pressure by anybody. So that was the standard of medicine in those days. You'll remember, 5th day there was a number of people. So I think because it was general medicine, we never called them specialties those days. And so I hope we will enjoy this session by improving our relationship better. Our knowledge is already good, but our relationship should be better. And I think a good general physician is any day better, any day protective, any day logical, any day more ethical than a half-baked specialist. So I think, thank you very much.
Thank you, sir, for this enlightening talk and for emphasizing many basic points which we need to learn, which we need to impart to our younger generation. We are highly honored you are here to grace this occasion as the chief guest. I would request Dr. Selvaraj to honor Professor Srinivasan with this medal and the shawl. Shall we all rise to our feet and give him a standing ovation at this time? Thank you. You may be please seated. I next call upon Professor Dr. S.S. Annamalai Swami to felicitate.
went through some of the events happened for the API in the southern region. So probably you may remember the API Madurai chapter was inaugurated, we conceived in the ward number 10 of, that is the medical ward, first unit, the first room, that is the teaching room, the demonstration room, that room we sat together and formed the Madurai chapter of, or Madurai branch of API, and from there it gone, many, events have been occurred, particularly the Crown it all, we had the national conference of API. That was really a very big event, applauded by everybody as one of the best organized events, both academically and socially. And the whole thing, probably the chairmanship or the stewardship of Professor K.S. was instrumental, and I was part of the team. And I am very happy to say at this juncture, I was involved in the inauguration of Tuticorin chapter of APA also. It was called those days TTK, Tuticorin, Tinnevelli, Kanyakumari. It was not inaugurated in a fashionable star hotel or anything. It was inaugurated in the house of one of the industrialists of Madurai, the Tuticorin. And it was a very small event, about 20 people attended, and that is the beginning of API in southern district of Tinnevelli, Tuticorin and Kanyakumari, and now they have gone leaps and bounds, particularly under the stewardship of Dr. Selvaraj and Arul Raj. And to crown it all, Arul Raj has been elected as the national president of the API, which is a rare event. He has already had the post of national president of IMA, and to crown it, now he has become the API president. It's a real, it's a real opportunity and recognition for his untiring work on the API activities. Similarly, Dr. Selvaraj also has been a very able lieutenant to Dr. Arul Raj, and as a reward to his untiring effort, he has been elected as the National Governing Council member of API, and I think he has been elected for a second term. I think we wish him all success, and very soon I think he may even follow Dr. Arul Raj and become the national president of API. Because it is a real reward for the hard work. And as has been said, this neurology, today's main topic is neurology, and Professor Srinivasan is
and the dedicated chair of Tuticorin branch of API, you have segregated the subspecialty from the broad specialty. If you go to MCI, broad specialty. I mean, what happens? Now, cardiologist will only link to heart. And if there is any blood urea which is little high, he will hand it over to the nephrologist. And if there is a abdominal pain or some black stool, he goes to gastroenterologist. And if he has a lack of sleep, he goes to psychiatrist. What is the end result? End result. Patient is seeing any number of doctors and emptying his pocket. Agreed. Doctor is losing his face. When you were a single doctor, there was no violence. Have you ever heard? Professor K.S. was talking about C.R.R. Pillai, one of the gem of the, physicians. Example. And that type of a person will never be opposed by anybody. Because the trust he has created, the trust will come only through, broad specialty, not through a micro specialty. You have a patient with acute coronary syndrome, and you can't immediately write, to see the cardiologist and go away, say. That's not the way that, we should work, but that's the way we are being trained. That is why I was encouraging this topic, and the right person to do that job is Professor K.S. I am sure, see, we want to stress the key theme of this is internal medicine is the father, is a broad specialty. And because we see the patient as a whole, you don't see him system-wise or specialty. We will not be able to treat. If you take diabetes, you will have diabetes, you will have hypertension, you will have dyslipidemia, she will have coronary heart disease, she will have CKD. Who is the team leader? Team leader is only physician. Team leader is the only physician. I am very much stressing that internal medicine, specialists should be the team leaders, and they can use the services of a cardiologist if it is needed. Because you have been taught, that is what, I have written to the medical council also. You are, you have passed, MD medicine and certified in internal medicine and its subspecialties. That is what I asked the government. Otherwise, the court of law also asking you, can an MD medicine, thrombolize a patient? All these issues are there. But as clinicians, if we understand that we should focus fully on the patient, not on the system. There's a theme for it. There are excellent topics available. Already we are 20 minutes late. I wish this meet a great success and declare it open. Thank you very much.
We thank you, Dr. Arul Raj, for all the advice that you have given us, and reiterating that basic courses, the main person is the physician who is the leader of the team. And I hope the next generation will take heed to this advice. We thank you, sir, and we are very proud that and honored that you are here today. We would like you to be honored with a shawl.
1 minute, Professor K.S. wants to say 1 minute.
I think Dr. Arul Raj as we are born in stressing, though it's delayed, it's a part of the show. Let me tell you only one example. Pandit Jawaharlal Nehru, was responsible for Chandigarh. He planned Chandigarh, and in Chandigarh I'm talking of Chandigarh about 10 years ago. You can go in the midnight at 1 a.m. or 12 in the midnight and with address and tap the house, and you'll be right on the right house, because the sectors and streets were so nicely planned. You can't do it in Madurai or Tirunelveli. In the night you will be assaulted because you'll be knocking on the wrong door. And he appointed one engineer, brilliant engineer of the country, national engineer, as a Bakaranangal Dam chief engineer. So he has to travel a lot in the forests near Bangladesh and other places, and has had many head injuries, and none of them produced loss of consciousness, and he was quite well, but he developed some dizziness. So Pandit Nehru, for some reason, consulted the physician in Delhi and sent him to a top cardiologist in Bombay. I think all of us know him, I won't tell his name. Every year he sends a New Year greetings, which is 50 pages of qualifications.
that
Not,
day.
and the first patient, and only the first one is MD degree, all the rest are 100 degrees from given all over the world, top cardiologist. And he was treating this man, this engineer, for 10 years for dizziness with beta blockers. Beta blockers are given because of cardio-neural connections, and so the sympathetic drive that causes arrhythmia, and they believed that beta blockers help. So, but I didn't think he examined the patient properly at all. And then he developed increasing headaches. He was then referred to Professor Ramamurthy, who was the head of the Department of Neurosurgery in Chennai. Top neurosurgeon in the whole world, I can tell you. And of course, the top most in our country, next to Chandy and so on. And he asked me to examine. I can tell you all this because I am, தொழிலாளியா இருக்கணும், முதலாளியா இருக்கக்கூடாது நம்ம ப்ரொஃபஷனில். You must carry the kit in your hand. I'm glad Dr. Selvaraj has given a kit so that you don't do the knee, miss the knee jerk because you didn't have the knee hammer. Anyway, whatever it is, unless you have the kit, you will incomplete. It will be incomplete examination. So I examined, and I used to be given 100 rupees for a case. It is a very big amount in those days, just to write the case sheet. Many people will call me to write case sheets. Even in Madurai, I was doing out to cardiologists, nephrologists, tetanus people in the middle of the night, all sorts of things. Writing a case sheet means you should be responsible for the findings. You have to take the blood pressure, you have to feel the pulses, and so on. Anyway, it improves your knowledge and training. It is not a subordinate work, it's a good teaching work, and you learn a lot to write a case sheet. And then when I examined him, I found he had no vision in one eye. Totally, he was blind in one eye. And I told him, I'm sorry, sir, you seem to have a very advanced lesion and you think to use blind. He said, nonsense. You know whom I am talking to? I am the national engineer. You think I can be blind and work like an engineer for years? I said, I'm sorry, sir, I apologize if I had a mistake, but I think you don't have any vision in one eye. You can try it. So he closed the eye and found he's totally blind. And I think all of us should know this. The slow loss of vision in one eye, all of us will never know. Because we compensate with the other eye and carry on our lifetime unless something falls on the healthy eye, the eye dust or something, and then you realize you're totally blind. And that was I'm telling you of a national engineer seen by several doctors in Calcutta, Bombay, top cardiologist for 10 years on a beta blocker for dizziness and nothing. And then I looked at the x-rays taken in Calcutta for several years. He has had many head injuries because he was traveling on a jeep. All of them showed an increasing cellular tumor. The cella is totally destroyed. But they're all looking only for some other problem. When your mind is not there, the brain does not use your eyes to see what you want. That's what happened. And he had a very large pituitary tumor and died on the table because it was referred by Prime Minister, and Dr. Ramamurthy said, if we say no surgery, they'll think we are unfit as surgeons. So we tried, and it's a very big one into the hypothalamus. Now I'm just telling you this, that people, and another one more example to tell you, there was a patient with Guillain-Barré syndrome in Trichy, very rich man, and I was asked to see him from Madurai. Any amount of fees is not a problem, by Dr. Mahadevan, who is a very good general physician. There are many people like Arul Raj and Selvaraj who are safe for the patient. They are one of those safe people. I'm not talking, they are very good, very expert safe, but they are safe people. They know what is not there. We will diagnose what is not there because we are specialists. And then what happened was, I gave some steroids because we didn't have immunoglobulin in those days. It is a classical Guillain-Barré syndrome without a facial palsy. Loss of reflexes and loss of power, but good sensations. And he recovered completely. And then I was not very happy. I told Mahadevan, you can't recover so nicely in 4 or 5 days. So I think something is wrong. The diagnosis, when you collect my fees, don't worry, but don't call me next time. He will definitely come back to you. He came back again with Guillain-Barré syndrome about 6 months later or 1 year later. This time Dr. Mani, M.K. Mani was called from Chennai to examine him, because they thought it must be an electrolyte problem, renal problem. So mild urea, as Arul Raj said, a little bit of creatinine, a little bit of urea, and makes you a nephrology. And then because all of us get a little bit old age when a kidney fails, we have little urea, but that can divert, it should not divert our attention from the basic disease. And Mani thought it was hyponatremia, and a laboratory obliged him, and he gave sodium, and he became totally all right. This time, same patient whom I treated is Guillain-Barré syndrome, and again he developed Guillain-Barré syndrome, third episode of paralysis. This time Mahadevan called me, sir, they want only you, they don't want money again. They think you are more examined better than him. So I said, both of us are right at that time, but we may be wrong tomorrow. And the second exam I have written, he had a slight splenomegaly, a small lymph node in the neck. I don't know whether it is connected. It must be something, blah, blah. And so I refused to come. But he said, you must come because they want you only. This time I examined, there was a lymph node, and I wanted a biopsy. But Mahadevan is a very clever fellow. He has already done a biopsy and got the diagnosis. It is a reticulum cell sarcoma, which will present like recurrent attacks of Guillain-Barré. So both of us were wrong, and Mahadevan was right. That's a general physician. I think there are several instances where you are with the patient more than the specialist. You are longer with the patient more than the specialist. He has more trust in you, and therefore you know what mistakes you have done. Many of us do not know what mistakes we have done because they never come back to us again. Thank you.
Thank you, sir. We'd love to listen to you, but learn from many of your past experience and admire you for the great memory that you have of all the past events. I'd like to honor Dr. Arul Raj. I call upon Dr. Madhiprasan to honor Dr. Arul Raj with the shawl. I now call upon Dr. Rajan to propose the vote of thanks.
A warm welcome and delightful good morning to you all. On behalf of our API Tuticorin branch, my sincere thanks to the great organizer of this mini conference. My sincere thanks to Professor Arul Raj and Dr. Professor Selvaraj. Both of them are very dynamic in organizing many number of events in PL City. Thank you, sirs. And also my sincere thanks to all the guest speakers, right from Professor K.S. He is always coming from Madurai, irrespective of the tight schedule. But I don't want to say irrespective of the age. No. Sir is always young. His neurons are so fresh, enthusiastic and dynamic. If anyone wants to have a role model, want to be young, please follow Professor K.S. Equally, Professor Arul Raj also. How they are dynamic, you know. Thank you. And the rest of the guest speakers, Professor Dr. K.S. and my sincere thanks to Dr. Ilamujan and Professor Kannan and Dr. Ram Subramanian and Dr. our Selvaraj sir also, and the chairpersons who are also going to share these sessions, right from Professor Princess, Professor HJD of Medicine, Kanyakumari Medical College, and Dr. Rajapal, best friend of Dr. Selvaraj sir, and the next chairpersons, Professor Morgan and Professor Subramaniam sir, and the next chairpersons, Dhanushkodi sir, Lesman sir, and Arul Prakash sir, Ardi Kannan, and Professor Elango, the real Corona warrior, who is also going to share the last session, and the next chairperson, Dr. Vimalapal also. And my sincere thanks to the presenters, especially Ankita and Faizur and Manigandan, who is also present the cases. And my sincere thanks to the audio people and video coverage, Jai Shankar. And also my sincere thanks to the DSF Grand Plaza for providing wonderful conference hall. And also my sincere thanks to the sponsors, especially Sun Pharma and Beat Pharma and Carewell Pharma. Thank you for one and all. And also my sincere thanks to Professor Annamalai Sami sir, Madhiparam sir, my mentor Dhanushkodi sir, Vairamuthu Raja sir, and Soundarya ma'am sir, and Dr. Muthuswamy sir, and my sincere thanks to one and of you who assembled here. Thank you.
Thank you, sirs. We have now come to the end of our inaugural session. Thank you, one and all. We shall now go on to the scientific sessions of the day. Okay.
As you can see in the slide, internal medicine gets 2+, neurology gets only 1+. And you survive because of medicine, not because of neurology. And anyway, I think well, there will be a lot of overlap in the cases, messages we discussed today, because there are other speakers going to talk about cardiology, gastroenterology, and other specialties. I'm sure we can't avoid an overlap, but it will be stressing the points rather than repeating the points. So I suppose you will bear with the speakers for that point. Now there are it's now realized that with more and more investigations and diagrams that the coronary arteries are blocked before the cardiologist diagnosis or the patient himself diagnoses it. If all the 3 arteries are blocked and collaterals are poor only, they go to the cardiologist. Before that, he goes to other specialties for a tour and ultimately lands with the right specialist for various symptoms unrelated to heart. Now, as you see, a recent large Chinese study, there are only 2 large studies by China recently. One was about corona from Wuhan state, and the other is the study of 20 or 40,000 patients we studied. They found that ischemic stroke patients develop myocardial infarction the first 3 days, completely unsuspected in the ICU by the neurologist, and without any new previous ischemic heart disease also. And this myocardial infarction has all the typical features, the STT changes and sometimes even Q waves, and you find the echo shows post-systolic and diastolic dysfunction. Troponin is raised, BNP is raised, so there is no question about the myocardial infarction. And common factors, of course, are risk factors like diabetes, hypertension, smoking, alcohol, it may be there. But then older age and high NIH score refers to the neurology. It is the more unconscious the patient is, more disabled the patient, the more likely he is to have myocardial infarction. In fact, myocardial infarction presents a stroke to the neurologist with the highest score values, and you find all these investigations are positive. Now, 40% of ischemic stroke patients have significant ischemic heart disease, but they never had any cardiac symptoms and never had a cardiac investigation appropriately at the proper time. So I think without doing a cardiac investigation, no neurologic examination is complete. And you must, that is to save the patient from tomorrow's death. In our ICUs, very common, they come with a gate of nephrology, go through cardiology, or come through cardiology and go through nephrology gate. The hospital benefits either way, but the doctor loses his diagnosis and patient. So I think the message is that they're all combined lesions in every patient. I'm not talking of embolic strokes, I'm not talking of other causes, I'm just talking of ischemic heart disease and ischemic strokes, which is are the commonest causes of neurology and cardiology. Next one. Sorry, I'm sorry. Now about carotid atheroma. This is a very important point. I have done some original work in Madurai on this, and that is the diabetologists now think the greatest marker for autonomic neuropathy is the carotid stenosis or intimal lesions measuring the carotid artery, because it's invariably affected in diabetes at some stage or other, and autonomic neuropathy is one that kills the diabetic patient earlier than the doctor can even imagine to have. So, 50% of people with diabetic neuropathy who have small fiber neuropathy, that means that's why a pin has been given in your kit, All that you need is a small safety pin. Why safety pin? Because with the same pin in the clinic, I don't want you to transfer HIV from one patient to another patient. These are very cheap, so that you can throw the safety pin. You need not sterilize it. It's easy to carry in your bag, and you can use it for other purposes at other times. And the loss of pain and temperature, but even retention of vibration sense and good reflexes in a diabetic neuropathy shows that he is going to die in the next 5 years of some form of autonomic neuropathy. Most of them have autonomic neuropathy, and they have sudden cardiac death or some other problem. The cardiac death may not be due to ischemic heart disease, but due to cardiac arrhythmias, which has been initiated by diabetic autonomic neuropathy. So I think it's very important to do the simple test of testing for pain and temperature in diabetics to have this complication. And they found that carotid atheroma is highly related with this, and they found it's a marker for autonomic neuropathy in diabetes and maybe the cause of disease, morbidity and mortality. However, as you can see, in Madurai, we have had more than 20,000 bypass surgeries, and I have analyzed many of them, and out of which we found both in, I have done it in GH, I have done it in Ramachandra, I did it in Madurai also. This applies to all the hospitals. Large number of patients. Let me tell you straight away to the younger generation, if you want to report about any finding which is not observational alone but not also comparative alone, you must have a minimum of 500 patients on whom you should have reported the finding, and a minimum of 500 in whom you did not find the disease or the finding. For example, you report about hypertension and chest pain. You must have 100 patients, 500 patients with chest pain and 500 patients who did not have to have your value compared. Not less than 500. This is very important because they are common diseases. You can't report on 100 patients or 200 patients. You may be wrong. Somehow statistics is valuable only when it is very large. But your statistician can always help with even 10 cases, alternate cases, abnormal cases and so on. You can publish a paper. But that is statistical lying. Statistics itself is considered to be a lie. It will be a better lie. That's all. I think for common conditions like diabetic hypertension or whatever other like headache, reporting on 500 patients is not enough. You must have 500 control patients to report that. And you find, this study therefore found out that of all the thousands of patients we studied, not even 10% have carotid artery disease, in spite of massive myocardial damage due to triple vessel disease and so on, with a very low left ventricular output and so on. So I think carotid stenosis is not severe in our country, but it's becoming more and more visible because of our easily available sonology, both to the cardiologists and the neurologists. This is just my observation, and I found therefore it may not be, whatever we read in the West may not apply to us. Even now we know that 25 to 30% of people, young people, 20 to 40, walking on the streets of Europe have got severe coronary artery disease of more than 2 vessels, but they have never gone to the cardiologist. They have not started doing this. I think it's occurring even younger age, not only in India, but even in the Western countries. It's just being recognized now. Next one. Sorry. Now the link between the brain damages the heart not only by ischemic heart disease due to atheroma and infarction, but very often unrecognized by diseases with autonomic nervous system. Autonomic nervous system is a very interesting condition because it's neither controlled by neurologists nor the cardiologist. It is autonomic. It is like our Madhiyil Kootachi, Manalathil Suyachi. It's like this. Therefore, both of us miss, both the cardiologist and the neurologist, because it is somewhere in between, and none of us will take the responsibility. And I think many of these things happen due to cardiac arrhythmias and blocks and so on. You will see it in subsequent slides also. And you find ECG lesions, changes in the brain lesions without ischemic heart disease, any large number of patients. As you all know, when the brain suffers a subarachnoid hemorrhage, you will have characteristic infarction changes in the ECG, but they are all reversible in 3 days or 4 days. So you should not frighten somebody. You should treat the stroke and not the heart, because it anyway secondary, that is due to autonomic nervous system, not due to ischemic heart disease. But the ECG changes tell you it's ischemic heart disease. Even echocardiogram may mislead you. I will not go into the subject. You also know about the stress cardiomyopathy, Japanese syndromes, in which even young people with massive mental stress, you find an acute fatal myocardial infarction. Next one, sorry. Parasympathetic function and sympathetic function, therefore, are very important in anybody. All that you have to do is take the blood pressure and the pulse rate, possibly in the standing and the lying position, and you get some idea about the autonomic nervous system. You not go for bladder symptoms or erectile impotence. And I think you find that the iatrogenic causes include various drugs like hydroxychloroquine, amiodarone, metoprolol, haloperidol, etc. They all contribute in our polypharmacy to autonomic neuropathy, particularly involving the heart. All of us know that in status epilepticus, commonest problem is tachycardia, but more often than that, in at least 10 to 20% of patients, you find cardiac asystole is the cause of neurology. And unless you have an ECG linked to EEG, we will be missing very pleasantly and ignorant of this combination, which kills the patient, and not blame the brain for his death. It's the heart that killed him, but because you have missed it. And you must have in every epilepsy admitted in the ICU unit a ECG monitor. Without that, you should not do it. I will show you an example. Next one. A 7-year-old school girl, this was published recently in the API journal. I think if you read API journal and Journal of Neurology and New England Journal of Medicine, I think you would have read the entire medical literature, and I am doing it as much as possible, so it's impossible because you get so many journals on your table. Our national journals are so superb, both physician API journal and neurology journals, that we cover 70% of medical literature very nicely, adequately, and with proof, and supplemented by New England Journal or American Journal, whatever it is. BMJ has become local, entirely local. I used to have in my fingertips 5-year BMJ when I appeared for MD exam, cover to cover, and I would answer any question. But now I find if you read BMJ, you will be backward, because there are a lot of British problems discussed rather than international problems. Whereas New England Journal is still a very good journal, but you must supplement with API and the neurology journals of India. Then you will complete whatever you have missed from your teacher, you would find it on your table. Now, 7-year-old girl repeats episodes of loss of consciousness. So they thought it was epilepsy, anticonvulsants were not effective. And then the video EEG and ECG showed long QT interval with periods of cardiac arrest also. And they immediately recover because the cardiac arrest was not caused by heart, but by the brain. And there was no, then they gave propranolol, high dose, even for a child of 7 years, they gave with 80 milligrams twice a day. I think the reason why they give such a high dose even in a child is because the QT prolongation becomes fatal with polyarrhythmias only because of sympathetic stress. That's one of the reasons. So they found to reduce the sympathetic stress with a non-selective beta blocker, not a cardioselective beta blocker, as propranolol. So this child are recovered. And you can see here 3 types of congenital QTS syndromes occur with, first type 1 occurs with sympathetic stress, type 2 with auditory and emotional stress, and type 3 occurs even in sleep. So I think ECG is a must, and very simple, simplest, easiest, cheapest investigation you should have to save the patients from bad neurology. Next one, sorry. I should just like to tell one small thing here, and very interesting. Lot of stick sinus syndromes for which ECG helps, which they present to the neurologist and easily missed, with a benefit to the neurologist and the radiologist, but troublesome damage to the patient. As you can see here in Sixth Sinus syndrome, I just want to recollect one thing. In Coimbatore, I was witnessing a DNB examination, and the examiner was, I'm sorry, being an old man, I will tell you some old stories, but they are very relevant today. And Dr. Vaidhyalingam, professor of cardiology from Vellore, I don't know, Arulraj may remember, and the chairman may remember, and she was an examiner. And she brought about 10 X-rays and asked Dr. K.S., find out which X-ray is abnormal. Because that was the question. She is going to give 10 X-rays to the candidate. And just to ask them to say which X-ray is abnormal, then they get 50% of the marks. And then if they say what abnormality it is, then they get 75% marks. And that's how we examined. And two of them had a coarctation with a rib notching. And she herself could not, with poor vision or poor memory, she wouldn't pick it up. I said, 2 of them are abnormal, please pick it out. I helped her. Anyway, the candidate was given, a brilliant gold medalist was given a case who had repeated fainting attacks. And the ECG was in favor of Sixth Sinus syndrome, but there was no clinical correlation. And immediately she asked for a microscope. A cardiologist from Vellore, examining a patient in Coimbatore, asked the supervisor for a microscope. I said, why do you want a microscope? Neither a cardiologist, neurologist has any benefit out of it. No, bring it first. Then I got a microscope, and a cover slide. She just pricked the child and the patient, a 15-year-old girl, and put it onto the table and just put the cover slip on this. Did not add acetic acid. The cover slip gives anoxia to the blood smear. And I could see a lot of sickle cells in that on the table in the examination by a cardiology examiner. That's a diagnosis, not Sixth Sinus, not any other neurology or epilepsy, repeated episodes of loss of consciousness, and Vaidhyalingam diagnosed it in the examination herself. And then, madam, how did you diagnose this so quickly? Which is a very rare condition, sickle cell. Dr. K.S., where is she from? She is from Ooty, Udagaman. Sickle cell disease is common there. That's why I thought of it. I mean, I think neurology is also a little common sense, and the common sense guided by a better sense of the examiner. I think that was the case of sickle cell, no problem. I'll show you about this example later on. And you can see here in Sixth Sinus, its embolism is, pacemakers do not prevent embolism because it's not the heart rate that causes the embolus, but it is the clot that occurs in the heart and various problems. Now, this is the final message of atrial fibrillation stroke also. Now they find there is no need to correct the atrial fibrillation. You reduce the heart rate, slow atrial fibrillation is okay. And what is needed is an embolus which is most harmful. Repeated echocardiograms should show whether there is a blood clot in the left atrium. That will save the patient than reverting the atrial sinus rhythm. That may be more harmful than helpful. Next one, sorry. Now, very simple slide for juniors, not for seniors. In an ICU, if you have a drowsy patient for various conditions admitted with ventilators and so on, supported by drips and drugs, and you find that if you have to look at the blood pressure, heart rate and respiratory, all are important in the ICU in spite of all your modern gadgets. I think what you see in the monitors many times go after. I had a very stupid experience in Apollo Madurai one day. The ECG was flat, the respiration was absent in the monitors, but the patient was alive because of some disconnection. And none of us know how to connect it. So we had to call the mechanic engineer. But we were all alarmed and had an alarm bell running. Patient is dead, patient is gone, please come. And their patient was fully alive, but the monitors were dead. Some connection went away. And I think so the monitors are not, we had a lesson in ECG and EEG and EMG from top people in the world coming to India, Bombay for a conference and teaching us with their electronic technicians standing at the back of the instrument. For every wrong decision we made, that man corrected the mistake. Because many of them put the cursor on the wrong wave and measure it and give a brilliant lecture. But you put the cursor on the wrong wave. The wave is really outside the oscilloscope. And then the electronic technician corrects it. Top people in the world from United States, Europe and UK came with the technicians and their own machines to do good cardiology, neurology in India. So I tell you, therefore, we are not electronic pundits. And many mistakes we do. I tell you a small example. Sorry for digressing. In Stanley Hospital, I was working under Dr. Prabhu as an MD student. Myself, Madana Gopal, and fourth day he called me. Everybody says you're a bright student. Can you answer me some question? Yes, sir. Yes, sir. RBC count, WBC count. I answered MCV, MCHC, and then I made some mistakes in some MCHC. So he said, Dr. KS, you can't play 5 balls in an over. How do you want to do MD general medicine? You are not even the 6th ball. Sorry, sir. I will correct. I mean, he just he pulls you down sometimes just to know that he is better than us. But everybody thinks MG Prabhu is not as good as a physician as other physicians, but that's not true. He has a lot of common sense, not medical sense. But we lack the common sense. We have got a medical sense. That's a problem. And then he presented a case of abnormal cardiac arrhythmia. Dr. Pillai was there, Dr. Krishnamurti Nair was there, and in the clinical meeting at Stanley Hospital, and patient was there with chest pain or vague non-cardiac chest pain, but it suited us because the ECG was abnormal. We call it cardiac because the chest pain was due to something else. And all of them made a wonderful diagnosis. Cardiac, all of them are cardiologists, Pillai, Krishnamurti Nair and others. They all made and then he said, sorry, I'm having some headache and we'll discuss this case next time. So next clinical meeting, he brought the case, patient was laid down. This time he took an ECG, it was normal. Now tell me what drugs I have given. All of them mentioned some drugs. He said, no, I only took an ECG on another day. The other day, electric trains were running. And all that you saw was electrical arrhythmias, not cardiac arrhythmias. This is, a small lesson learned from a teacher whom you think is no good, who is brilliant, more brilliant than us. The electronics and the technology still can make you make blunders in the ICUs if you are not good in electronics. We cannot be good in electronics, so I think we need an electrician or electronics chap somewhere. Our cursor is stupid cursor. You put the cursor anywhere, it will measure. And you can say the rate is, I think, blah, 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 blah. But you can go wrong. I have seen this in many international conferences. What we miss, the technician helps you. This is just about the gadgets we are using in the ICU. Next one, sorry. Now you can see here, BP is high, heart rate is low, respiratory is low. The diagnosis here is high intracranial pressure, not hemorrhage, not sepsis, or any metabolic acidosis. Next one, sorry. So that's the diagnosis. Circulatory shock is unusual in brain injury. Although he is unconscious, semi-conscious, it is not neurology, it is some other problem. Head injury never causes low blood pressure. It's always high, or tachycardia will be there, never bradycardia. And you should be very careful, except in certain situations. Next one. Syncope is fully reversible. Most of the syncopal attacks are cardiac, but some of them are neurological, some of them are outside with hyponatremia and so on. We will not go into the subject. I'm sure other people are going to say something more about it. And the neurocardiogenic, I didn't touch it. Sorry. Yeah. It's a vasovagal syncope in which you get bradycardia, usually in a prayer, young girls who have not missed their breakfast, fluid inlet. So when they are standing posture, the BP goes down. There is also a bradycardia, but nothing happens to people. Some eye movements may be, some jerks may be there. And when there are real convulsive pseudo, we call it convulsive syncope. But convulsive syncope, the ECG will be normal. There is nothing wrong in the brain. It's the cart which makes them unconscious for small periods and so on. So I think the heart and the brain can mislead you in diagnosis in short episodes of reversible loss of consciousness, and you must be very careful. Next one. Sorry. Now this is one of the conditions which causes ectatrial myxoma with postural, or even without posture they can have repeated episodes of loss of consciousness. Next one. This is a very important case. This lady came to a neurology center with repeated episodes of abnormal behavior, clumsy automatisms, and but not fall. But she was confused, wandering, took her seat, then became normal, then apologized. So we call it temporal lobe epilepsy or complex partial seizures, and that was the right diagnosis. And therefore, but we found that in spite of and it developed a status temporal lobe epilepsy. We call it complex partial status. So she has been admitted in the ICU. Not my case, somebody else, some other case. And you will find here, if you carefully look at the ECG monitoring during EEG, the first arrow tells you, the arrow A, 4 traces, shows EEG changes in the left temporal chain. As you can see here, here, that EEG tells you there are epileptic discharges, and then the cardiology is okay then, and then the heart stops beating. You get a cardiac asystole here for several seconds. EEG is still normal, then EEG also becomes flat. So both are bad for some time, and then EEG picks up earlier, cardiology picks up. And therefore, I think there won't be any simultaneous block of the brain and the heart, because as you know, when the heart is stopped, up to 4 minutes the brain can survive, and then you get a permanent brain death. But when the respiration stops, up to 20 minutes you can still survive without any ventilator or respiration. So I think you have more time to resuscitate the patient when there is a primary respiratory failure, not with a cardiac failure. 4 minutes is too long a cardiac period. So the message is very clear that whatever the loss of consciousness in this case was cardiac and not neurological. That's why it did not respond to anticonvulsants very well. So what they did was, she had a left temporal lobe tumor also. And you know, temporal lobe tumors can affect the heart more often than frontal lobe or parietal lobe tumors. And cardiac arrhythmia may be the important cause of status epilepticus. That's a message in this case. And unless you do ECG and EEG together in the ICU, you mustn't worry about the artifacts. But you can. Now in Mayo Clinic, they found that many deaths in ICU occur because neither the neurologist nor the cardiologist picks it up. So they have appointed nurses. They have given a EEG recording and ECG recording to nurses with audio clips. The audio will click sometimes and call the patient, call the nurse that the EEG is abnormal or the ECG is abnormal. And immediately she gives some appropriate treatment or calls the appropriate specialist. They trust the nurses more than the doctors. Even in UK now, in the ICUs, nurses are paid more than the doctors, indirectly or behind the scenes, because they think they are the people who diagnose abrupt complications in the ICU, because they have to call the doctor. Doctor will be in the next room with a veterinary nurse or somebody else or smoking, and he has to put out both of them and come to test. They are not at the bedside when complications occur. It's a real fact all over the world. We are not even ICU doctors. Even the best of ICUs don't have doctors in the ICU 24 hours. They are in the second room or the next room. I have visited many ICUs in United States and UK. I can tell you, the person by the side are the nurse, not the doctor. So I think they're paying more indirectly, and you know it gives, and they're giving antibiotics also immediately. And then the bacteriologist professor comes and shouts at them, how did it start the antibiotic? So I think there's a lot of ego problem going on, but patient is saved. Senior doctors like us will appreciate the nurse, but juniors will quarrel with them. Who asked you to start this antibiotic? Who asked you to do this? All this. Because you don't, I am a cardiologist, I am a nephrologist. This is happening in UK. I saw it personally happening in a UK ICU very recently. I think the problem is that what is needed is the quick response, not a delayed good response. Delayed response can be bad, nothing may happen. But at the bedside, and that's the message of this slide also, that these things are picked up in Mayo Clinic by audio helped electronic devices by the nurse, and they can report epileptics similarly, just as you pick up embolus when you do an echocardiogram from the embolus makes a click and you realize that. Next one. This lady had a transvenous pacemaker used, and for some reason they continued that, and the resection of the tumor was done. So she had both neurology and cardiology, but picked up only by monitoring the ECG and EEG, and not either alone. Next one. Okay, these are various arrhythmias, but some of the electrolyte problems are seen only in the ECG, much better than your laboratory. Laboratories mislead you more often. Any laboratory can give you whatever calcium you want, potassium you want. Most laboratories, I'm sure all of you have seen in ICU, potassium level will be 6.5, 7.5 and all, patient will be alive. According to your textbooks, above 5.5 milliequivalents, you can't be alive. But your laboratory is alive. So I think laboratories are a problem. Anyway, it happens even in UK. Everywhere it is like this. Somehow potassium levels are very unreliable. I'm sure all of you will agree with me, but you are much better than me because you're closer to the patient more often. Next one. Now this is again in neurology, diagnosing cardiology. As you can see, in Kearns-Sayre syndrome, you have complete heart block and various neurological signs in the ophthalmoplegias and myopathies and peripheral neuropathies and so on. But the basic problem is the heart block. Next one. A complete heart block paced by a pacemaker. This is again a publication in Indian Journal in Bombay, and you can see he has an ophthalmoplegia, ptosis and so on. That's the reason for neurology consultation. But in fact his problem was complete heart block with, this is a mitochondrial disease. Mitochondrial diseases are transmitted by mother, not father, and they can affect all systems. You should suspect a mitochondrial disease if somebody has a multi-system disease. If he has neurology, cardiology, myology, peripheral neuropathy, etc., it may be a mitochondrial disease. And then you have to do the appropriate investigation for that. And they are transmitted only by the mother. So if you do the pedigree chart, you will find the mother is responsible. But what is sad about all men doctors is that the child inherits the intelligence from mother, not father. All of you know it is the X chromosome that gives intelligence, not Y chromosome. We cannot give our wife, and we should not be. You should be happy about your wife because she gave the intelligence. But the development later on maybe it depends on you or the neighbor, but that doesn't matter. But the intelligence was given by the mother. So similarly mitochondrial diseases, the mother is to blame, but the father is to diagnose it. Next one. Sorry. I saw a case in Tanjavur years ago, 1965. I was a lecturer of infectious disease. In government service, lecturer is equal to head of the department. So I was sitting next to DME, which none of the other assistants can sit, because I was the head of the department. It's very difficult to go to meet the DME in those days. Now things have changed. The peon will send away, you have to go back to Madurai and come back 1 week later, spend your own money. DMEs are very big people in our days. Now things are changing a little bit, I suppose. As a lecturer in infectious diseases, I was doing a lot of medicine because I had a lot of time to do. And a lady came with pain in the left shoulder, and mother-in-law was very rude to her because she could not grind the dough with the left hand. He fainted. But the right hand she was doing okay. The mother-in-law said, "This is ridiculous. That means you don't want to do work. Then why did you get married?" This sort of quarrel was going on. And then I examined her. I found a pruy in the left supraclavicular region, and it was a case of subclavian steal syndrome. You can see in this another case, the subclavian steal syndrome with a block in the subclavian artery. And you will be interested to know that I used to go to the postmortem room in Stanley, which many you postgraduates even don't do that nowadays. Many of us don't go to the postmortem room. And in the plenty of cases of phallostretology. And in phallostretology in those days we used to do only a subclavian pulmonary anastomosis, not a total correction. For some reason total correction is not possible. And you find in many of these cases you are producing subclavian steal syndrome because you are unresting the subclavian artery to the pulmonary artery. And that's why the origin of subclavian steal syndrome was Blalock-Taussig operation correction. Taussig was a medical student who learned this point also in postmortem room of connecting the pulmonary artery. Helen Taussig is a very big cardiologist in the United States. And in the postmortem room only they thought, why not we connect the pulmonary artery to subclavian artery in a phallostretology. This is extracardiac surgery. Okay, now this patient, the stent was, this was done in Madurai Apollo, and you will find that he recovered. He had a vertebro-based ischemia clinically because all the blood in the brain was being stolen when the left arm is exercised by the reverse flow in the vertebral artery from the brainstem to the left arm. So whenever they use the left arm, they faint for manual reasons. So I think a neurologist should know that asymmetrical problems can be due to extracerebral causes. Next one. But this is another case published in API, same syndrome but due to cervical rib. You can see the cervical rib there, and that was resected. You can see the gangrenous fingers, pre-gangrenous fingers, but this was cervical rib. I must tell you one interesting thing. In Coimbatore, sorry, we will tolerate some of the old history. There was one Dr. Rao who was removing all the cervical ribs in Coimbatore. He has done hundreds of cervical rib resection. Anybody goes to chest X-ray, he said, tomorrow you'll get a paralysis. Right arm will go, brain will go, get it out. And 95% of cervical ribs are asymptomatic. It's just a radiological abnormality. But you must find out which may cause you harm. That means that's a different topic. But he was removing all the cervical ribs. So proved to the world that removing cervical rib benefits the doctor more than the patient. That's the greatest final conclusion of the talk, of his research. But sometimes cervical rib can be symptomatic and harmful, like this in this case. Again published in API journal. Next one. Blank spells can be neurology or cardiology, as you can see here. Of the neurological causes, many of them are listed here, and I will not go into it. Next one. A child with fluctuating stupor. I have seen some children in my clinic throwing my ophthalmoscope outside the door and doing all sorts of mischief, breaking the torchlight and so on. But then they are physically normal, there is no abnormality, there is no cerebral palsy or mental retardation. And then if you do an EEG, you find they have a seizure disorder and give anticonvulsants, they are better children, they get better marks. I have found in my experience two conditions in which the child's marks improve after they consult a neurologist. One is hypothyroidism, the other is complex partial seizure. Because they otherwise look normal, but they are very poor in the school. But then the IQ improves remarkably after they consult you, and that's because of this. Collect the thyroid or the neurology. Next slide. Sorry. This patient, this child had non-convulsive status epilepticus. Next one. Non-convulsive, so we missed it. There is no convulsion external. It's in the brain but not in the limbs. As you can see here, that's a normal ECG, spindle alpha, wonderful spindle alpha. And then that's EEG of this patient, and with the drugs it's becoming more and more normal and so on. Next one. Very rewarding condition because we are able to treat it very well. That's all. I will stop with this. I just one or two more slides. Next one. This child came to us with not to me, somewhere else reported congestive cardiac failure, but not due to a cardiac problem. The congestive cardiac failure was caused by a cerebral problem. And as you can see, this is an aneurysm of the vein of Galen. You detect it by just a stethoscope because there is a loud bruit in the neck with a hydrocephalus, and that made us think the bruit should come from elsewhere because there is no stenosis of the intracranial vessels, and it came because of the high output cardiac failure due to increased flow as you get in severe anemia. Severe anemia, you get loud bruits in the neck, but most of them are venous bruits, but this was an arterial bruit. Next one. That's an aneurysm that has been clipped, and the child is better. Cardiac failure improved, heart size reduced, but with a neurological surgery. Next one. These are the various complications of QT syndromes, various polymorphic arrhythmias, sinus, tachycardias, bradycardia. Next one. Next one. Next one. Next one. Next one. Is that all? So thank you very much. Thank you. In fact, the sickling is quite common in Coimbatore if you keep it in mind. You have to give only repeated transfusions, and then if you, for 1 year you find all that you have to do is to they are now finding some genetic treatment for this. And interesting thing I was telling Dr. Madhi Prakasam yesterday was, our genetic research is not supported by ICMR or ICSR, supported by bacteria and viruses. Because we have to, the virus only can go and split the gene and put the right amino acid, or a bacteria. No neurologist or a big PhD or a Nobel Prize man can go into the cell to change the genetic structure. It's very interesting. So we need the viruses to teach us also and to kill us also. That's the point. That's the point. Genetic enzyme, except enzyme therapy in genetics, the other reversible genetic disorders, there are only a handful of them in the whole world, are done by bacteria and viruses, because they only can go into the cell, into the chromosome, into the and disturb the chromosomal arrangement of amino acids. I stop with this and we'll go on other.
Varieties of cases linking heart and brain. Similarly, usually atherosclerosis is a generalized disorder, as you told. It may affect all the systems, including heart and brain. Plus, you have presented some rare cardiac drugs are used for neurology. Antiarrhythmic can be used as anti-epileptic. Anti-epileptic can be used as antiarrhythmic. Discussion. We'll have the discussion later. Now we will proceed with the next session.
Yes, sir.
Stable staircase steps versus helicopter
Sir.
approach in medical diagnosis.
Sir, we have completed that session, sir. Yeah. Thank you, sir. Endocrinologist Tuticorin to chair the session and introduce the speakers. Speakers, your timing for the session will be 10 minutes for presentation and 5 minutes for discussion. We request all faculty to stick on to the timings, please. Thank you.
Just a minute. I thank all the organizers for giving the opportunity. Thank you very much.
So you still learn a lot. So rheumatoid, the topic given was neurology and rheumatology, or rheumatoid arthritis. But on the whole, the neurology in rheumatology is more in connective tissue disease and vasculitis. So there is only a less number of patients who have complications just due to rheumatoid. So rheumatoid is the commonest of rheumatological illnesses. So you can read the literature. Extra-articular features do happen predominantly in the lungs, kidneys, skin, and also neurology. So early rheumatoid diagnosis is important because it has affects mobility and mortality and morbidity. So even if you have missed 3 to 6 months, you get to have some morbidity. So functional decline begins early on in rheumatoid, and by 5 years you would lose more than 50% of your mobility. History of RA, so back in 17th century, willow tree bark used to treat first the inflammation, subsequently aspirin, salicylic acid, and you can see neurologist Duchenne described the word arthritis back in 18th century. Philip Hench discovered steroids in 1950s. From then on, it has taken a higher end, and in the early part of 21st century, we have cytokine blockers like MAB, monoclonal antibodies, and CD20 blockers. So that's about the history of rheumatoid treatment. Until we get the biologics, we had all DMARDs. We still, that's the main drugs in most of the patients with rheumatoid arthritis. So methotrexate, sulfasalazine, hydroxychloroquine are commonly used. Other drugs are not many, preferred because of complications rather than the benefits. And if you look at the biologics, we have from 2000 onwards, lots of MAPs. I'm not going to go fully into that, but since the approval, every year we get new bio drugs. So rheumatoid and neurology back in 19th century. So initially described by Peters and Willard in 18th century, and later Bannatyne described peripheral neuropathy either due to rheumatoid nodule affecting the nerves or deformities affecting the nerves. Commonly you can see, or we all will see, the features of carpal tunnel, because the wrist is the common site of involvement in rheumatoid, so you get carpal tunnel syndrome, and also you can have tarsal tunnel syndrome if you have ankle involvement. Subsequently in 19th century, peripheral neuropathy complicated by arthritis by Ball and et al. And then rheumatoid arthritis prognosis based on the peripheral neuropathy. So that was described by Ferguson and colleagues. So pathophysiology, usually the complement mediated disease. So in the synovial fluid or in the pannus, you can demonstrate complement activation and triggered by both ACPA and rheumatoid factor. And because of the complement activation, you get a cytokine cascade and also a programmed cell death called netosis. That's a newer concept, but it's extracellular traps involved in the development of pannus and the destruction of the cartilage. So this is a schematic representation of neuroinflammation in autoimmune diseases. So you get a lipopolysaccharide as an inflammatory agent, and that is activated, that triggers the inflammatory cascade with activated monocytes, and then it crosses the blood-brain barrier, and then it produces microglial cell activation and formation of neutrophils and netosis. So that's the apoptosis happening inside the cerebral cells, so that's triggering the inflammatory pathway. So in these, TNF was the first cytokine proved that it has more inflammatory properties. Subsequently, interleukins and other factors have also been proven to be in the pathophysiology of inflammatory effects on the brain. And other way around, so people who are on these treatments like TNF alpha inhibitors, they have been shown that they do have less evidence of development of Alzheimer's disease, or so it's more protective, the TNF inhibitor therapy. And functional MRI studies have also proven to show the same evidence. So what are the common manifestations? So the synovitis can compress the adjacent structures, so either in the spinal cord, peripheral nerves, or in the limbs. So untreated rheumatoid can have vasculitis, which is more peripheral, so rheumatoid vasculitis, and they may manifest as mononeuritis multiplex or peripheral neuropathy. You can see even foot drop or wrist drop with these because it's affecting the vascular nervorum of the vessels. Sensory neuropathy have also been described, and 40% of rheumatoid vasculitis have sensory neuropathy, and they can also have mixed motor and sensory neuropathy. This is a picture depicting various involvement of neurology and rheumatology, all rheumatic diseases. So in terms of inflammatory pathways, how do we image the brain? So these are T1, T2 weighted MRIs relevant to rheumatoid. So I can just read a couple of them. So white matter lesions are associated with the higher levels of S100B protein, which is a potential surrogate marker for blood-brain barrier disruption. So these have been proven back in 2012. And if you look at the T1 weight images, then you can demonstrate high increased volume of basal ganglia in the rheumatoid patients compared to controls. So you can read, so that is all already proven with neuroinflammation. So it's very closely linked. So this is a very good review back in 2006, Quaternary Journal of Neurology and Medicine. So common involvement is cervical spine. The PGs all tend to learn. Rheumatoid doesn't affect the spine except cervical spine. And even the cervical spine, the common rheumatoid lesions affect C1, C2, so atlantaxial subluxation, basically due to the pannus and further erosion. You do all get a cervical spine degenerative disease along with it, but it's lower down, C3, C4, C5, C6. Some people tend to have good response with immunomodulators and IV therapy, but a few others may need urgent surgery to correct the cord involvement. Peripheral nerves, So the carpal tunnel, which I alluded to earlier on, that's an intrapid neuropathy. So usually it settles very well with local therapy, failing which you may need carpal tunnel release surgically. So that also is recommended. And nerve conduction studies have proven that 6% of patients with RA had carpal tunnel compared to other patients. So neurology and rheumatic diseases. So this is another table which was give you a summary of all the rheumatology illnesses and neurology. So AA subluxation, polymyositis, mononeuritis multiplex, peripheral neuropathy, nodules in the central and peripheral nervous system, rheumatoid vasculitis causing stroke and neuropathy. These are only pertaining to RA. So these are the common patients I have come across. Symptoms of tingling and numbness in the fingers, which will be early on feature in rheumatoid, early rheumatoid. And the neck pain and stiff neck, always think about AA subluxation. Foot drop is due to the peroneal or sciatic nerve, and the strokes because it's a vascular disease. So rheumatology, as all the professors were alluding to, I still feel rheumatology is a multi-system disease with more internal medicine concept. So even in UK, US, or in Vellamal or Madurai, we are closely attached to the physicians. All other specialists have different knowledge, different room, different departments, but I prefer to stay with general physicians. And all my patients are under general physicians in my absence. So headache and seizures can also be manifestations if you have vascular disease, and neuropathic symptoms too. These are all common symptoms we come across in a patient with just rheumatoid arthritis. Apart from these, there are rare manifestations like extrapyramidal type rigidity, which have been described in journals. This is a case report. Or you can have hemispheric masses, like rheumatoid nodules. You can have pannus. You can have involvement within the cerebrum. So that's, you can see lesions, hyperintense signals in the cerebral hemisphere. So this was a good article on cerebral hemodynamics in patients with RA, and also self-limiting rheumatoid meningitis, presenting manifestation of rheumatoid. This is a patient who had, under treatment suddenly developed sixth nerve palsy, which responded. Imaging were all normal, but responded to IV steroids. So it's a mononeuritis involvement, cerebral. This was, we published psychosis with the vasculitis, but Takayasu, quite young girl. So I'll finish with these two slides. This is a patient referred to me as possible scleroderma. Anybody want to say what is the diagnosis? Patient is 12-year-old. So it's a progeria. Okay, it's not scleroderma. Okay. So biosimilars, we do a little bit of research in Vellamal and try to publish with the undergraduates. Now we have MD, PGs also. This is a learning slide for patients coming to rheumatology OPD. So PGs can take it afterwards. So education is the most powerful weapon. So even you can use to change the world. And Prof. KS, I believe, is part of Abdul Kalam's vision. So all of us do have the talent, but we also have to improve by listening to all the stalwarts and teachers. Clinical medicine is really the key to make you successful. So this is, please read, this is a correspondence from Dr. KS, published in Neurology India, about his previous acquaintances in UK. So all in Queen's Square, London. So thank you for the opportunity, and once again thank the organizers, Dr. Selvaraj sir, Rajan sir, and the Doyen of API, Dr. Arulraj sir, for giving us the opportunity, and Mohan sir also. Thank you.
Thank you, Subramanian. Right, so there's a little bit of change in the program, and before going into that, I think, any comments?
No, this is just a comment of a story that it's made more and more interesting. And I visited the pediatric cardiac disease, and we were all frightened by other doctors in India that Reye's syndrome is very common. You should not give aspirin in children because Reye's syndrome is a complication. And at least 4,000 cases he has treated, none of them had any Reye's syndrome. Reye's syndrome occurs when you give aspirin for arthritis, only if there is a virus infection, basically. Otherwise, without virus infection, you don't get Reye's syndrome. Reye's syndrome is acute liver failure with hypoglycemia, a wet brain. It's called wet brain, dry liver syndrome, and so on. That's one point I learned, that you should not be scared of giving aspirin, even in high doses in children, even if they don't have any possible virus. The second, about cervical dislocation, I have an interesting story. This is a patient in Tanjavur Medical College where in our days, the professor of medicine will do a lumbar puncture ceremoniously with all PGs and assistants attending. 20 people will be watching this professor doing a lumbar puncture. In Chennai also I have seen, maybe in those days. Now of course everybody does lumbar puncture. Now, and I found the patient was put on, that was a patient with neck pain and abdominal, some mild arthritis, but nobody thought of any problem. We thought he is having some weakness of lower limbs, so they advised lumbar puncture. And his sensorium was blurred. As the professor finished the lumbar puncture, he became tetraplegic. Instead of course we got some CSF, but CSF was normal. But he produced another disease, severe tetraplegia. And then when I took the X-ray cervical spine, I found gross atlantoaxial dislocation. Now, atlantoaxial dislocation can be due to rheumatoid arthritis or can be due to congenital. Very often I have seen several cases congenital dislocation. This case was referred to Chennai, and Dr. Ramurthy said, "This is horrible. Why did they do lumbar puncture?" You know the way we do lumbar puncture in our hospitals. A ward boy should come, put him on the left side, sit on his neck or back, bend him, and then we poke his back. And all this traumatology is more than rheumatology. And then Dr. Ramurthy passed an order, no physician will hereafter do a lumbar puncture without doing a cervical spine X-ray. That is the order, government order. No physician. Physician means physician. He will never say physician. He will say physician. No physician should do. This is a general hospital order. Our premier hospital in Tamil Nadu, GH. We should not do lumbar puncture. I'm saying it's a good lesson for us also. If there is something wrong in the neck, you bend it further and poke him in the back, you produce all the hemodynamic changes. Anyway, that's interesting. The other point is about some new ideas about strokes in rheumatology, like SLE. SLE is a rheumatological condition, and we get hemiplegia. We thought so far it is cerebral vasculitis. They have done several postmortems. They found it is not cerebral vasculitis, but it is an embolus from the heart, from the Lehmann-Sachs endocarditis in SLE. Similarly, in tuberculous meningitis, we get hemiplegia. We think it is tuberculous arthritis, but in fact, postmortem, you can never demonstrate a tubercle bacillus in the wall of the cerebral vessels. You can demonstrate in the meninges, not in the wall. It's all immunology. It's immunology and not bacteriology. Very simple. You get hemiplegia in tuberculous meningitis when medullary blood is occluded. He's hemiplegic because he has vasculitis, but that is immunology and not neurology. I mean, bacteriology, because you cannot demonstrate in thousands of postmortems done in Bombay bacillus in the wall of the. Whereas in syphilis, when you get a hemiplegia, you can demonstrate the live spirochetes in the blood vessels. Syphilis is a very active disease, both for the enjoyment and for the acquirement. Thank you.
Right. Let's just.
So rheumatoid arthritis is a systemic disease. So it will affect all the system. Especially in a PG exam, one of the main question is the extra articular manifestation of rheumatoid arthritis. It will affect all the system. So Dr. Subramanian has nicely pointed out all the neurological problems in rheumatology. Now we will go to the next. It is a case presentation, neurocardiac case syndrome, case presentation by Dr. Anvida.
Just before inviting the postgrad, let her come to the podium. Just before that, I want to grab a couple of minutes to talk about Dr. Professor K.S. I'm a student, undergraduate and postgraduate student in Madurai Medical College under him. Actually, it's a very honor to be here. I'm a little nervous. He's just a giant and legend. I can keep talking about him for hours and hours. And he has inspired many people. I see him not as a neurologist, but I see him as Professor KS. He has imprinted in many of the young brains to imbibe so many characters. And you would have seen during the previous lectures that he's funny, but he sends a message to your brain. So much of knowledge gathered from the days of 1960s. It's very, very invaluable for the postgraduates. You will never ever have such an occasion in your lifetime. You will learn very, very things. Many things which you don't find in the textbooks. So that's the thing. So I remember the days, உட்கார்ந்துட்டு இருப்போம், சேவு வாங்கிட்டு வர சொல்லுவார் 11 o'clock after the neurology session. எங்களுக்கு சாப்பாடு கொடுத்து டீ கொடுத்து கொஞ்ச நேரம் வெயிட் பண்ண வச்சு he stays for long hours. இங்கே ப்ராக்டிஸ்க்கு உடனே போக மாட்டார். So he loves teaching and we still remember many things. And actually I wanted to become a neurologist, but I ended up in endocrinology. That's a different thing because of the inspiration. But my son has taken up neurology in Arkansas University. I had a chat yesterday with him, and the point I learned from Professor KS, I just discussed with him. A case came to Arkansas State University, a 27-year-old girl with disorientation, and on examination he had paraplegia, but she has got cerebral syndrome also. He is disoriented, confused. So it's not a spinal level problem. They thought probably this is something cerebral. And they attended, so they invoked the stroke team because they started doing the thrombolysis and all that. So stroke team was invited, and on examination, my son happened to be a resident in neurology. So he said, it doesn't look like something, it looks like not stroke. And the discussion as we had, I said, paraplegia of central cause should be a sagittal sinus thrombosis, or something could be, some tumor in the falx cerebri. So that's a point I learned from him. And I added a bit because being a young girl, maybe sexually active in the United States, maybe on pills, oral contraceptive pills, maybe I've added the thrombosis. He said, exactly, we broke our head for hours and hours and then finally to the conclusion. Because the point is, the clinical neurology I learned from him. I didn't look at the MRI and things like that. So he was so impressed. So maybe a kind of so many things, he may touch many people's lives if you keenly observe every little word he utters from his mouth. So we are all so privileged. So even I treat so many patients because of attending his classes, not from the textbooks. So don't waste time. Keep your eyes and ear open always. So with that we move on. There is a bit of changes in the program, unfortunately. So we'll just present, move on to the neurocardiac syndrome, a case presentation by Dr. Ankita, SAH, PG. Over to you.
Hello. Good morning. Neurocardiology is the study of neurophysiological, neurological and neuroanatomical aspects of cardiology, including especially the neurological origins of cardiac disorders. The neurocardiac axis is the link to many problems regarding the physiological function of the body. This includes cardiac ischemia, stroke, epilepsy, and most importantly heart arrhythmias and cardiac myopathies. The constant communication between the heart and the brain have proved invaluable to interdisciplinary fields of neurological and cardiac diseases. Many neurological problems have their origin in cardiology, therefore neurocardiac axis is important. Here we present a series of 5 cases to demonstrate this axis. First case. A 37-year-old female came to our emergency department with complaints of slurring of speech and deviation of angle of mouth towards left side since 45 minutes. On examination, pallor was present, pulse was 88 beats per minute irregular. CVS examination showed loud S1 and opening snap. CNS examination, motor aphasia was present, deviation of angle of mouth to left side was present. Lab investigation showed HB 8.6 and ECG had P mitral with LVH. In view of loud S1 and opening snap, bedside echo was done for the patient which revealed RHD with moderate MS and dilated LA. Provisional diagnosis, acute CVA RHD anemia. Course in hospital, CT brain showed no evidence of hemorrhage and she had come within the window period, so she was thrombolized. After thrombolysis, there was improvement of 80% in her speech. There was high suspicion of LA clot and thus TE was planned that confirmed there was no LA clot. MRI showed cortical infarct involving the left posterior parietal cortex. Final diagnosis, CVA left MCA territory infarct, RHD, mitral stenosis, intermittent AF and anemia. Lesson, every CVA patient should undergo cardiac evaluation. Second case, a 24-year-old male came to our emergency department with complaints of breathlessness and chest pain, followed by right-sided weakness. There was history of him going to deep sea diving on the same day morning. On examination, patient was drowsy, responding to painful stimulus. CNS examination, plantar was extensor on right side and power was 0/5 in both upper and lower limb. Lab investigations were within normal limit. ECG showed sinus bradycardia. Provisional diagnosis, CVA right hemiparesis and decompression sickness. Course in hospital. Initially, patient was treated with high flow oxygen therapy, steroids, low molecular weight heparin, antiplatelets and antiepileptics. Echo showed multiple small microbubbles seen in right atrium and right ventricle. MRI showed the pattern of atypical posterior reversible encephalitis syndrome. On second day, patient became oriented with time, place and person and started responding to verbal commands. Follow-up echo shows loss of air bubbles. On third day, patient was able to sit. Motor power increased from 0/5 to 3/5 on right side. Started taking orals. Intermittently went for sinus bradycardia which got settled by itself. Final diagnosis, decompression sickness with right reversible hemiparesis, intracardiac air impulsion. Lesson, echo is invaluable in DCS patients to detect air in cardiovascular system and any right to left connection in heart. Third case, a 70-year-old male brought to emergency with altered sensorium, not able to get up from bed since morning and not responding to any command. Patient was a known hypertensive, not on regular treatment. On examination, patient was drowsy, GCS was 5/15, blood pressure was 220 by 100 mm of Hg. CNS examination, pupils were bilaterally asymmetrical, fundus bilaterally, disc margin hazy with grade 3 hypertensive changes. Plantar had no response bilaterally. On lab investigation, it was within normal limit. ECG showed LVH. CT brain showed parenchymal hemorrhage at right temporal lobe involving right thalamus and intraventricular extension of bleed. EEG showed epileptic form activity. Provisional diagnosis was hemorrhagic CVA, ICH with IVH and systemic hypertension. Course in hospital, patient was started on antiepileptics, antihypertensive, steroids, mannitol and was taken up for surgery. Right frontotemporoparital craniectomy and evacuation of IC bleed was done. Now patient is in our ICU on recovery stage. Final diagnosis, CVA hemorrhagic stroke recovered after craniectomy and systemic hypertension. Lesson, in ICH craniectomy saves life. Hypertension control prevents ICH. Fourth case, a 90-year-old male came to emergency with complaint of sudden onset of multiple episodes of generalized tonic-clonic seizures since one day. On examination, pulse was 58 beats per minute and irregular. Systemic examination was within normal limit. Lab investigations showed RBS of 254 since the patient was already a known case of diabetes. ECG showed intermittent complete heart block. Provisional diagnosis, intermittent complete heart block, query seizure disorder and diabetes mellitus. Course in hospital, patient was given the loading dose of antiepileptics and immediately temporary cardiac pacing was done, following which seizures episode subsided. Permanent pacemaker was implanted the next day and patient was discharged in stable condition. Final diagnosis, complete heart block with cerebral ischemia and seizures, type 2 DM, patient recovered after pacemaker implantation. Lesson, every seizure check the heart, especially the rhythm. Fifth case, a 20-month-old male child presented to emergency with complaint of bluish discoloration of lips while fighting with his elder sibling, followed by fainting for few seconds. On examination, SpO2 was 81% on room air. Systemic examination, CVS showed systolic murmur heard best along the left sternal border that was radiating to axilla and back. Provisional diagnosis, cyanotic spills, cyanotic congenital heart disease. Course in hospital. Oxygen therapy was initiated and child was put in knee chest position. Correction of acidosis was done. Chest X-ray showed boot-shaped heart. ECG showed right ventricular hypertrophy. Echo confirmed the diagnosis as tetralogy of Fallot. Final diagnosis, tetralogy of Fallot with cyanotic spells, lesson, fainting with cyanosis, speeds for cyanotic congenital heart disease. Lastly, I would like to conclude by quoting our Chief Sir, Dr. S. R. Ulraj, the etiology of neurology, often lies in cardiology. Thank you.
So thank you, Dr. Angita, for your nice presentation of 5 cases of the different age. So younger age group to 90 years old. So the impression is, so clinical examination is very, very important. So all neurology cases, you have to look for pulse, BP and cardiac examination. Especially in nowadays the rheumatic heart disease incidence is coming down because rheumatic fever is very rare nowadays. But 10 years, 15 years, 20 years back, so one of the commonest cause for young stroke is mitral stenosis, the atrial fibrillation with the stroke. Many patients will of rheumatic mitral stenosis will diagnosed only after that, after the stroke or even during pregnancy, especially during pregnancy also on the labor table only, not by the gynecologist. When they develop some dyspnea, and they will call the physician, they will diagnose mitral stenosis. Like that, many patients will come to the casualty with the seizure disorder. When you examine the pulse, it will be very low, that is 20 or 30, that will be complete heart block. So if you correct this, patient will be all right. So all the cases will be very nice. I request our Professor K.S. to comment on this.
Related inside and outside the house.
For the seizures patient with a complete heart block, what medicines were given for seizures? Because most of the drugs are given for seizures supposed to cause still more the bradycardia, bradyarrhythmia. Pacemaker is different, but at the acute stage.
And this is one thing cardiologists can also correct me. We know we give dilantin or phenytoin sodium for digitalis induced cardiac arrhythmias, one of the ideal drugs. Digitalis induced atrial tachycardia with block. Phenytoin is one of the very good drugs. But we are giving thousands milligrams of even, very large doses of digitalis for thousands and 10,000s of patients all over the world. But cardiac arrhythmia is never reported. I did some work on UK. I did the ECG in all these people, the epileptics who were on Eptoin, and for large doses. I don't know, this is something which cardiologists can answer, but we give that for the treatment of atrial tachycardia because it increases the conduction time of the AV node and therefore reduces the heart rate. Any comments by the cardiologist? Also tell me, propranolol, very high doses will give a migraine. 80 milligrams per day, years. They don't develop bradycardia.
But I think people transfuse, or infuse, give the infusion of Eptoin under the ECG monitoring, I suppose. So they pick it up anything that goes wrong. In corporate setup at least, the people give the phenytoin or anything under the ECG monitoring sometimes. Yeah, IV phenytoin. Okay. Okay. Yeah, we'll move on to the next case series. It's neurology clinical challenges. The presenter will be Dr. Nandini, postgraduate from Thuthukudi Medical College. Over to you, ma'am.
Good morning.
Good morning, everyone. Today I am going to present an interesting case of cortical blindness. So, a 23-year-old female, right-handed individual, born to non-consanguineous parents, studied up to 12th standard, married since 2 years. She was a primee with 8 months amenorrhea, and she presented with history of repeated episodes of dizziness followed by sudden fall for the past 1 month. When we are inquiring about the detailed history, she was apparently normal before 1 month, and when she was at her 7th month of amenorrhea, she developed episodes of dizziness which was followed by sudden fall to ground without any loss of consciousness, and it is not associated with any palpitation, blurring of vision or complete loss of vision such as blackouts, and there is no other symptoms preceding or following the attack. The patient had similar episodes, 3 to 4 similar episodes in the past month, and she was admitted in our hospital. And even after repeated inquiry, she has no other positive history such as headache, fever, difficulty in walking, difficulty in using her upper limb, and unsteadiness while walking, and any blurring of vision. She is not having any history of diabetes, hypertension, tuberculosis or seizures, and there is no history of any previous hospital admission for similar complaints. When we are inquiring about her personal history, she does not use any OCP pills and any other drug history intake, and there is no history of substance abuse or toxin exposure. She takes both non-vegetarian and vegetarian diet, and there is no significant family history in her family. General examination: she is conscious, oriented, afebrile, she is paler, no cyanosis, no clubbing, no jaundice, no generalized lymphadenopathy, no pedal edema. Her pulse is 90 per minute, regular, normal volume, no specific character, felt equally in all peripheral vessels, no radiofemoral delay, and no vessel wall thickening. Her BP is 110/70 mm of mercury in right upper limb in sitting posture. And after 2 to 3 minutes of standing, her BP is 100/70 mm of mercury in right upper limb. Her temperature is normal and JVP is not elevated. There is no markers of any premature atherosclerosis and no external markers of vitamin deficiency. In a higher mental function examination, she is emotionally stable, she is oriented to time and place, she is apathetic, she does not make eye contact when she answers our questions, and she is quite inattentive. Her word output is decreased. She answers only to our questions in 1 or 2 words or in 1 sentence. Her comprehension is intact and her repetition is intact. She does not read when she is asked to read a newspaper, and she does not names the objects which is shown to her. But when she is given a paper and asked to write her name and given a pen, she writes her name and small words. On cranial nerve examination, she is able to identify smell in both nostrils. While checking the visual acuity, she is having only perception of light in her both eyes, and her color vision is impaired. When she is asked to name the colors of any object shown to her, she usually confabulates some random color names, and she could not also match any colors if a color matching table is given. Her visual field examination could not be done due to because she cannot follow fingers, and bilateral light reflex is preserved. An accommodation reflex could not be tested as she could not follow fingers. Her fundus examination is normal, and on oculomotor nerve examination, both eyes are in primary position, no ptosis, no squint, and there is no nystagmus. Instead, she confabulates as she is seeing 2 or 3 fingers, and frequently she is answering wrongly, like she is seeing 3 fingers or 2 fingers. And when we are doing Menas reflex, as her eyes are approached by rapid movement of fingers, she is blinking her eyes, which denotes positive Menas reflex. So extraocular movements are full, which is tested by Kaman saccades, and other cranial nerve examination is normal, and spinomotor system examination and sensory system examination is completely normal. Cerebral function tests like finger nose incoordination test and dysdeudokinesia could not be tested due to her inattention, and extrapyramidal system examination is completely normal. Her gait is normal, but when she is asked to walk, she walks as she is unaware that she is blind, so she bumps into the intervening objects, whichever object is kept in her way. So this is a video of her walking. While walking, she is bumping into the object placed in between. So there was no other signs of meningeal levitation, and her spine and cranium examination is normal, and her other system examination is also normal. During the course of illness, she constantly denies that she is blind, and she confabulates randomly as she is seeing everyone. And she was, for her condition, she was taken for elective cesarean section, and an alive baby was delivered. Her intraoperative period was uneventful, and BP was monitored throughout. While continuously monitoring the BP, we could pick up transient elevations in BP, and she was started on antihypertensives. Post-operatively, she became not aware, she completely became unaware of the surgery and her baby, and became apathetic, never asks about her baby, and does not even ask anything, and she became amnesic, that is, she could not identify any persons nearby. On investigation, her hemoglobin was 10.1, ESR, CRP, HIV, VDRL, hepatitis B, everything is negative. And she was evaluated with ANA, which is negative. And her CSF examination was normal with normal protein and acellular acellular smear. And her CSF, CBNet and culture sensitivity is also normal. She was also evaluated with autoimmune encephalitis profile, which is also negative. Her ECG is normal, and she was evaluated for cardiac disease, which is normal. So this is her MRI, which showed T2 and flare hypervitensities in the, which is bilateral and asymmetrical in parieto-occipital region, predominantly involving the white matter, suggestive of vasogenic edema due to PRES. So this is a case of cortical blindness due to posterior reversible encephalopathy syndrome in the antepartum and postpartum period. So patients with bilateral occipital lobe damage can present with complete cortical blindness. So these patients will be can be completely unaware that they cannot see, and they can confabulate some visual descriptions or blame that they cannot see due to the dim light, which was originally described by Anton and Babinski in 1899. And the patients can also sometimes describe the objects that they see, and they usually when they are asked to walk, being unaware that they are blind, they will walk readily and bump readily into the objects which are in the way. And some patients have preserved ability to react to visual stimuli, such as sudden movement in front of their eyes, and they will blink, which is called as blind sight or inverse Anton syndrome. And to differentiate this cortical blindness from the peripheral blindness, which is due to the disorder of eyes, optic nerves and optic tract, in disorders of eyes, optic nerves and optic tract, the residual vision will be completely absent, whereas in patients with cortical blindness, like in our case, they may react to elementary visual stimuli such as brightness, size and movement, whereas they cannot perceive finer attributes such as shape, color and depth. They can also, on recovery, they can also have visual hallucinations such as unformed hallucinations in irritative lesions and complex hallucinations, which is called as Bonnet syndrome. So to diagnose a case of cortical blindness, usually they should have a blindness associated with absence of any ocular pathology, like normal fundus and normal slit lamp examination in our like in our case, and with the preserved pupillary light reflex, with the presence of associated and signs and symptoms like cortical symptoms like transient amnesia and other cortical signs. So the etiology for cortical blindness can be due to stroke involving bilateral posterior cerebral artery debris lesion. Transient cortical blindness can occur in traumatic brain injury, migraine, epileptic seizures, hypoxic ischemic encephalopathy, and posterior reversible encephalopathy syndrome, like in our case. In other cases like meningitis, vasculitis, and degenerative disorders like CJD, posterior cortical atrophy syndrome of Alzheimer's disease, and it can also occur as a complication of iodinated contrast procedures such as arteriography. So these are the case reports in the literature in which they have presented with bilateral cortical blindness as the isolated feature of posterior reversible encephalopathy syndrome. So these two are the case reports of isolated cortical blindness as a presenting feature of PRESS. So isolated cortical blindness can be a sole manifestation of PRESS, and it has been reported in the literature. Visual disturbances are common in PRESS. It can range from non-specific blurriness of vision to visual hallucinations and complete loss of vision. The basic pathophysiology of vasogenic edema is in the Pareto-occipital distribution was attributed to the reason. So PRESS-related isolated complete cortical blindness is quite rare, and early recognition and treatment can prevent permanent neurological damage. Thank you.
So, thank you, Dr. Nandini, for presenting a nice case of cortical blindness. Dr. Nandini is a DM neurology student of Thoothukudi Medical College, and she was a MBBS and MD student of Thoothukudi Medical College, and a gold medal winner of clinical examination, and university first in MD General Medicine. She got a gold medal in the Tropicon, Kodaikanal also. So one should have high index of suspicion to diagnose cortical blindness. So it is a very nice case. I request case sir to comment on this.
Good clinical presentation, and all clinical neurology findings are nicely discussed. There are only one or two problems in this. Of course, posterior reversible encephalopathy syndrome, as well as even eclampsia, even pre-eclamptic toxemias, they affect mainly the posterior part of the brain because of poor sympathetic control of the posterior vessels. Autoregulation is poor in the posterior circulation, posterior cerebral artery and vertebral. So that's the reason why many other things are posterior. And the second point is the blood pressure, which normally you call it hypertension if you have 160, 90 or 100 or more than 150, 90. But in women, especially young women, if they had been used to a BP of 90 by 60, 100 by 80 healthy life, even 120 by 80 or 130 by 90 is hypertensive. They can develop eclampsia or fits. So you should not, hypertension does not mean always above 140/90. In women who are used to a lower blood pressure, even a BP of 140/90 is a severe hypertensive, and they produce mainly posterior vascular, cerebral posterior vascular syndromes. So this is a good case to illustrate the point. The problem in this case is that you said she has also got altered sensorium. She was not able to answer correctly. She was disinterested and so on, apart from cortical blindness. And I think it is a diffuse process in this case. Two investigations should have been done. I mean, will be more useful. One is electroencephalogram to know whether this was an encephalopathy and not just a posterior cerebral infarction. She had altered higher functions also, as you said. So an EEG should have shown more valuable slowing or sharp waves. The second point is in cortical vein thrombosis, all these things can occur. And a venogram, MR venogram also will tell you whether she had any venous problem. The only point against a cortical venous thrombosis is your ESR is very low. I don't know how, mostly women have high ESR because of various other problems, infection, anemia and so on. And then here the ESR was low. I used to ask the students what are the conditions you get low ESR. We are all prepared for high ESR. I ask them tell me conditions low cholesterol. This is a prize exam, but nobody will be able to answer. Because he said, nobody has asked me this question, sir. That's of course, that's okay, sir. Low ESR is congestive heart failure, and in polycythemia and so on. I mean, they're all the points. ESR was quite low, and but anyway, it excludes venous thrombosis clinically if the ESR was correctly done. But anyway, NMR venogram is easily done. It should have been done. I think she had EEG also must, because she had an encephalopathy, which fits in with the posterior reversible encephalopathy syndrome also. But one good thing about cortical blindness is many of them improve unless they are very deep injury, or because when I was working with Dennis Williams, 3 articles were published in Brain that people with cortical blindness, which is the same thing as hemianopia. If it is on one side of the brain, you call it hemianopia. If it is on both sides, you are calling it cortical blindness. they know if you shake hands with them, they correctly will shake hands with you, although they are blind. You can change your hand anywhere, they will blink. Because they proved by a lot of experiments in London that cortical blindness, they are having vision. They will, initially they knock down. After some time they know somebody is there and they will avoid him and go. They won't knock again Selvaraj. They don't need Selvaraj. But somebody is there, so they will walk. So their accidents are less and less as time goes on because the compensatory mechanisms occur. Cortical blindness is not a permanent disability. It will be useful to claim compensation and very other problems.
And you comment on color vision, return of color vision and stereoscopic vision, sir. So you tend to see that they get back the black and white color, and then probably some people take some time. Is it so, sir?
I don't know. I don't have any idea. I don't know how color vision is. That was spared here in this case, isn't it? Color vision is spared. It was affected. But black and white vision recovers usually or compensated. For example, the ophthalmologist will say black very nicely as saying they have got hemianopia or cortical blindness. But you test in the bedside, they will have fairly good vision. They won't knock against you. Visual loss is there, visual disability is not there. That's the important point for cortical vision. And normal people, reflex tells you it's cortical and not peripheral. And his reflex will be absent because vision is poor. Should be poor. But hysterical cortical blindness is more common than real cortical blindness. Much more common.
So thank you very much. I think the session is coming to an end, so we'll just move on to the next one. Thank you.
Thank you, sirs.
We will go to the next session by Professor K.S. Dr. K.S. used to say, whenever you want to attend a meeting or a conference, you first go to the topics, various topics, look at the topics. You prepare a little and then come to the conference or meeting. Then only you will have some understanding and you will have good retention in your subconscious mind. You can come with some prepared questions also. So with that in mind, I just looked at the topic, very interesting topics given by the organizers. Cauliflower is nothing but cabbage after college education. I did not understand anything because I don't know the various proverbs like this. Then I called Dr. Vimala Paul. She simply asked me to go through the Google search. Then I went there. There it was written as, it was given by the one person, Mark Twain. He was a genius author in America, and he was considered to be the father of American literature. He wrote 2 or 3 lines. In that, cauliflower is nothing but cabbage after college or medical education, anything like that. And both belong to the same family of plants, Cassica. And he simply wrote, the cabbage is a wild form and cauliflower is a cultivated form of plants. So with this only I gathered some news, and I guessed that basics are very important than the sophisticated things. And a doctor is a lifelong student. The eyes do not see what the mind does not know. So we must be going on learning things. Now we will hear more about from Professor Dr. K.S.
Good afternoon once again. Mark Twain said that with a very, he might have had many ideas because he was more intelligent than any of us. But our interpretation was that cauliflower is like a film actor, but cabbage is a domestic worker. More dressed, more visible, more impressive, more scented, more made up. And that's a neurologist. Hard-working general physician, useful to the patient, protects the patient, is the cabbage. We are all visible, we charge more, we are unavailable, we are not accessible, adoptable. But all these should be there to get an English, we call it an English vegetable in those days we called it cauliflower English vegetable, because of course now it's become Indian vegetable. That's the way. As you can see here, can you put off the lights so that you can see the slides? There are several problems in general medicine and neurology linked to them, where the diagnosis is made not by brain scans or complicated immunological investigations, but by just examining the patient with an e-hammer and tuning fork. Especially a large number of conditions where patient is not able to go up the staircase, falls very often, and he has got a proximal muscle weakness. So I have listed some of these conditions, common conditions, as you can see there. The hypothyroidism, all these conditions I have listed. You have a weakness of thigh muscles with or without reflex changes, and therefore there is a neurological disability. All of us do MRI scans and these patients to find out the absent spinal cord lesion. Most of them will have nothing abnormal, but MRI will show some disc prolapse, some other condition for which the orthopedic surgeon can make some money out of it, but not diagnosis out of it. And so I think the message is very simple. With just a knee hammer and clinical neurology, you can diagnose many of the conditions. Just do one or two more tests like creatine phosphokinase for the muscle, whether the muscle is involved or not. Then you get almost a final diagnosis, which you may not get by imaging investigations. In the United States, they have coined a new word now, called that all modern doctors and modern specialists are image worshippers. In fact, they present cases in international conference saying, I will now describe the patient. Now let me come back to the image worshippers. That's how they start their lectures. Because we have all become image worshippers. Without MRI and CT scan, a neurologist will get run back from the hall. That has become the problem now. So I think this slide tells you the image is negative in these cases, but final diagnosis is positive and complete and proved beyond doubt by just looking at the patient, looking at that and so on. As you can see here, let me recall you an instance. About several years ago in 1970 in Coimbatore, a lady came from Pollachi with weakness of lower limbs, unable to climb stair and even cross the front barrier in front of her house and so on. It was only about 6 months duration. When I examined her, she had spastic paraparesis, but very poor, very minimal sensory loss, and bladder was still retained. And I found that she had a positive Beware sign. Umbilicus was moving up when she raised her shoulder and neck. So I knew the level of lesion was T10. It's a Pollachi lady. It was in Coimbatore Medical College. And I found with my closed eyes, running my finger from head to lower abdomen, that there was no sweating of the body below the umbilicus, but there was good sweating above the umbilicus. Why I closed my eyes was I didn't want to be prejudiced by what I see, and also did not get distracted by the nurses, and also hand will point out the resistance. After all, even electrophysiologically, when we find low resistance, we know there is sweating. When we find high resistance, we decide there is no sweat, there is sweat. And therefore, this patient had a sweating level at T10. And I decided that this lady has a tumor because it was one leg first, the other, it's called Ellsberg's phenomenon. The Ellsberg's phenomenon was discovered from the patients by doctors like me. But Ellsberg discovered it by putting a balloon in spinal canal and compressing it with increasing pressures and produce the same findings. First you get posterior column affected, then only lateral column, because posterior column is thickly fibered and later to develop, and therefore earlier to lose in neurology. And he found one side is affected, then the other side, then both sides, then the bladder and sweating, and so on and so forth. So if bladder and sweating are lost, that means the lesion is deeper, and also it means it's bilateral. They are lost in bilateral lesion. It's all good to predict the prognosis and take up the case for your future, because if you are having a loss of sweating and bladder function, it's better to refer to a surgeon whom you don't like very much, because he is never going to improve that. Because in this case, it was 1965, about that time. And then I telephoned from Coimbatore to Dr. Ramurthy from Chennai. Sir, is the case like this? She is not willing for any investigation, but it looks like a spinal cord tumor. What shall I do? I said, your diagnosis is right. Go ahead with laminectomy. The district medical officer was an MS general surgeon, and in those days all neurosurgeons encouraged, can you hear me? Yeah. All neurosurgeons encouraged general surgeons to do head injury, because what is important is not a neurosurgeon. What is important is an accessible, available neurosurgeon ready to do something earlier and then late. So they were teaching this to all doctors in South India. And so he said, also general surgeon to operate. You are right, diagnosed right. No investigation is necessary. So we opened up the lady, and there was a huge meningioma, correct, on the T6 vertebra. So I think sometimes clinical neurology is as good as imaging investigations, provided you do it properly. And you can see here that all these conditions are very common. Hypothyroidism, when you get raised CPK and weakness of thigh muscles. Hypoparathyroidism, again, all that you have to do is to read the parathyroid hormone and look at the calcium values also. But most important thing is you find that the knee jerks are very definitely instructive and helpful. Similarly, in Conn syndrome, which is hyperaldosteronism, you find again thigh muscles are very weak, but the reflexes are very slow. Addison's disease, same thing. Cushing syndrome. So I think if you look at the CPK and the knee jerk, you get 90% of the diagnosis, and then you have to do only one of the two other biochemical tests, and you get the answer. Similarly, many endocrine conditions, as you can see here, diabetes in rejects is always lost even before you diagnose diabetes in that patient. And one thing in diabetes, I will tell you, share with the diabetologists here, so many. HbA1c is very misleading to the neurologist. It is very useful for all the diabetologists to discuss about diabetes, especially outside the country, enjoying their holidays in some company-sponsored trips. To again discuss when to meet again, than to find any solution. Now, the HbA1c is not reliable in neurology, because when I tell my patients, please bear with me for my rude behavior, tell some of my patients, sir, my HbA1c is okay. Even a collector said, then why did you say I should get neurology of diabetes? So, Baba, supposing somebody gets 100 marks in 100% of mathematics marks, 0 in geography, 100% in zoology, 0 in psychology, whatever it is. Totally, of course, you will pass. But you fail in many subjects. That is HbA1c. You will have hyperglycemia, you may die. You may be saved by treatment. Hypoglycemia, you may die. You may be saved by treatment. HbA1c will be normal, because it's a 3 months average. So that's why in neurology, we are advised not to trust HbA1c for diabetic neuropathy, for diagnosing diabetes, but repeated blood sugars, fasting and postprandial, and 3-hour oral GGT is advised, and not even the conventional AMG, for confirming diabetic neuropathy. It's very important. I mean, because high and low sugars damage you more. Just like your high glycemic index is more damaging than a low glycemic index. That's a very small point. You may have controversies, but that's my view. And then you find, therefore, in diabetes, the reflexes are always lost. And you can change your diagnosis if it is retained. Especially in knee jerk, because knee quadriceps is a very powerful muscle. So I don't go into this. You can look into any textbook, you will get all these findings, but it's better to have it even in your hand, because at the bedside you can make a diagnosis based on CPK values and reflex, knee jerk, many diagnoses, and confirm it later on by other things. Now, this is McCardle syndrome, where there is a myophosphorylase, a rare condition, myophosphorylase deficiency, in which the muscle glycogen is not converted into blood glucose. So when you exercise or ask them to climb staircase or do a two-step exercise or bruise, whatever it is, they get fatigued and cramps and fall down. But after some time they will do the exercise and they will be able to rise on the steps. It doesn't mean that it's hysterical. That's because the liver glycogen can still be converted into blood glucose, but muscle glycogen cannot be converted because it needs a severant myophosphorylase for its conversion. It's called second wind phenomenon. If something happens like this, you are almost sure you are having a rare metabolic disease called McCardle's disease, in which you get cramps on running and so on. We can again pick up and run, but again you will fall. Again you may not run the third time. So, and that's a condition here described, and you can also diagnose it by forearm ischemic exercise test, because you can produce lactic acid and pyruvic acid when you do an ischemic exercise, and by the values you can diagnose. I will not go into it, and the muscle biopsy will be useless. Now, this is a condition published in New England Journal of Medicine recently, this month's issue, January, it came in January, a few days ago. 3-year-old boy waddling gait, so that means he got a myopathy, but this is not inherited, there is no family history, so it's a metabolic myopathy. There is no family history of myopathies in the family, and his IQ was normal. He had a brief febrile seizure. It always happens. Any virus infection is provoked by fever infection, and things are much worse if you had fever or you did not have fever. Fever had nothing to do with it, but except to make it worse. Serum calcium was low, so that means he has got hypocalcemia. So the doctor gave calcium to improve this. He was having food allergies also to milk, eggs, peanuts, etc. This business of food allergy is very common in the West. Luckily not very common in the East like India, because I think we eat all types of foods at all times. Mostly we are on the road or not inside the house, and children I am talking. And therefore I think we are used to many insults and injuries we can tolerate. I call it maybe immunological tolerance, but I am calling you physical tolerance. But although he was allergic to milk, eggs and peanuts, the challenge tests were negative. That's the story of all allergy. Most allergy clinics are survived by negative tests, not by positive tests. Very, very common. There are some allergy pundits, but they can say it's correct. And then muscle power reflexes were all normal. So it was a case of hypocalcemia produced in a child who had restriction in the diet because of food allergy. I find calcium was very low, and ionic calcium was only point. Now this ionic calcium is something which we don't do routinely, but it is useful only. Ionic calcium is useful only in metabolic alkalosis or respiratory alkalosis, where you get calcium, low calcium and tetany. So very often that's a very rare condition. Most of our cases are easily diagnosed. But more important than that is the ECG. ECG reflects both the total and ionic calcium. It shows changes very quickly. But laboratory can be wrong. Two laboratories can give you different values and collect money on both sides. But it can be wrong. I'll tell you a small anecdote. I was a clinical meeting secretary in Tanjavur Medical College, and two powerful fighters, one on surgical side were Dr. Bhatt, on the medical side was Dr. Amaresan. They were in the audience. What happened was there was a young lady who had repeated vomiting due to pyloric stenosis. I can see the visible peristalsis myself. But the surgeon refused to operate for some other wrong reasons. Forget about this. I won't say what it is. But then I told him this Dr. KS is very much interested. He said, okay, transfer her. By the time she has been vomiting repeatedly, and she developed in the night some tetanic movements or convulsions. The duty physician was called because this lady was throwing fits. So he gave her diazepam intravenously, which was our practice in those days, 10 milligrams IV, slowly. There was no respiratory problem, and the fits did not stop. So they informed the surgeon, Dr. Butt, sir, the lady is going down, why don't you come and see? Dr. Butt came and saw the case and gave her calcium. He thought it was tetany. The physician thought it was convulsion. So he gave her calcium, and she became all right. He presented that case in the clinical meeting, and also, as usual, Butt was a very aggressive man, always rolling up his sleeves when he talks. So you want to keep a distance away from him, not for corona, but for physical assault. You keep away from him, because always he roses and comes, the way he argues. And he said, don't refer a case of convulsion or muscle jerk to a physician. They will spoil like this. Call us, surgeons, we'll diagnose. In the clinical meeting. And you know, people like Amarasan will never tolerate this. How dare a surgeon can talk about hypocalcemia when we are all physicians sitting here. What is hypocalcemia? Define that. How did you diagnose it? All sorts of things he asked. So almost they were coming to blows. Amarasan also, you know, as a man with physical assault more than verbal assault. Both were ready. And then I was a secretary, so I was asked to intervene and solve the dispute. So I said, wonderful diagnosis by the surgeon, advising the physicians how to do in the next case. I thank you very much for this. But let me tell you, calcium estimation can't be done in the midnight when the labs are closed. Even then you have to do 3 estimations in the morning without compressing the cuff and so on. And there are so many. And then you should know the serum protein. Calcium depends on serum protein. This lady has been vomiting repeatedly, starved, dehydrated, her protein even, therefore calcium will be low. So I am sorry, sir. I think both of us could have done one thing, physician and surgeon, taken an electrocardiogram which is available at the bedside, not used for several months. You can use it and say calcium is low. Calcium, very important, very important. So I think I have to solve the dispute that way. So both of them agreed that they should have done ECG. Amarasan took his seat and Butts took his seat, and we are educated. Now, but in this case published by New England Journal of Medicine, they did not do electrocardiogram. I don't know why. They did not do serum albumin also. But they called it hypocalcemia because they did the ionic calcium level, which I think they have got higher. I can tell you, instead of basic problems, they have gone to very high levels. Another New England Journal of Medicine case they published recently, they diagnosed Tay-Sachs disease, which I have diagnosed hundreds by looking at the fundus for cherry red spot. But they are diagnosing by biopsies of rectum, biopsies of liver, electron microscope, but not to the fundus. And then somebody in the meeting said, I think fundus examination was ignored. And his comment was also ignored. Published in New England Journal of Medicine. A very good journal sometimes is high technologically, but poor clinically sometimes, because there are nobody to point it out. So in this case also, I think he should have done the serum ECG, but it's not that. It's published without ECG and or a serum albumin. But I suppose ionic calcium have been done, so I think they have bypassed. They did the parathermone levels, they did everything, but not what we are capable of doing. And you can see here muscle power is normal. So this patient improved with conventional treatment, calcium, vitamin D and so on. I think that's the next slide. Yes, and bone X-ray showed demineralization. You can see the rickets change here. I think some of the Indians could have diagnosed very quickly, because we have seen a lot of rickets in our days, waddling gait with this typical X-ray of rickets. This was a hypocalcemic vitamin D deficiency rickets, but provoked by nutritional deficiency because of a vegetarian diet, avoiding milk, avoiding eggs, non-veg, etc., due to allergy and so on. And that's the purpose of this presentation. That clinically it was diagnosed, and just as X-ray can complete the diagnosis, and you can treat them with vitamin D, calcium, and they get better. But metabolic encephalopathy is very interesting. I showed you slides of metabolic myopathy. Metabolic encephalopathy is very interesting because you diagnose them because the pupils are normal in reacting. Patient is unconscious, pupils are normal in reacting, eye movements are normal or dissociate, but they are otherwise all the neurology of a severe coma due to brain lesions. And you can see therefore that you must insist on. I used to carry ice water, a small thermos flask and a syringe, because you can't be turning the neck here and there without knowing whether they had a cervical spine injury and so on. But you can syringe them if there is no air discharge. And you can, 2 minutes, just few ice drops in the air will immediately pull the ice to that side. And with a nystagmus, if the brain is okay, no nystagmus, but ice are pulled if the brain is, cortex is damaged and the brainstem is intact. So in this case, the eye movements will be impaired or dissociate, but it will be present. It won't be absent as in any other cause of head injury or brainstem injury and so on. Pupils will be normal. And with these clinical signs, you can diagnose as metabolic encephalopathy. So there is no for a lumbar puncture or a brain scan and so on, but we will do it anyway because all of us have to be employed. And you can see here, the EEG is always abnormal. And the CT scan is usually normal. All metabolic encephalopathies, whether it's diabetic ketosis or renal acidosis or hypoglycemia, it's now, small research work, I am showing this slide to know that for doing research work, you don't need a very high complicated computerized gadgets laboratory with ultrasound techniques and modern 3-4D echoes. Not necessarily. Clinical medicine can be done at the bedside even as a small institution. This research was done by me in Rajaji Hospital by just examining the patient before abdominal surgery. You know, I took abdominal surgery because their brain is normal. You know, the surgeons take anesthetic fitness, which means the chap is physically normal to fight with somebody as a neighbor, and therefore is fit for surgery, although not fit for social life. And those people therefore have a normal brain function, normal cardiac, ECG is normal, brain is normal, but there is an abdominal problem. So good case for us to do some research. I do this test before surgery, and after surgery when they remove the anesthetic tube and he is given normal oxygen, he is put in the recovery room, they allow me to do our test, look at the pupillary reaction, look at the eye movements with a cold caloric test. What I found in 50 cases was they are very healthy people, neurologically otherwise, cardiologically otherwise. That's why they are called fit for surgery, for abdominal surgery by anesthetist. And I found that the first thing to recover from anesthesia is pain. You pinch them, they move the limb, but they don't know where you are pinching because they are drowsy and still anesthetic and under anesthesia. The next thing will be the pupillary reflex. And the last thing to recover before they become fully conscious and answer all your questions after anesthesia, general anesthesia I'm talking, is the eye movements. They are dissociated in the second slide, as you can see here. They have not completely abducted. This is not completely adducted also. But here you find there is complete abduction and complete adduction of this left eye. This is complete. By this time he is already conscious, talking. And this is a very valuable test to tell you that this patient has been anesthetized and is a drug-induced coma. It is not a surgeon-induced coma. It's a drug-induced coma. And he recovers. Now, I should also tell you share this. I have seen at least 20 doctors in Government Rajaji Hospital, lady doctors, who are admitted for deep coma and almost brain death. That is, the eyes will not move, pupils will not react, and they will be on the ventilator. They have no blood pressure. They have all sorts of problems. Because, you know, phenobarbital is such a small tablet, and lady doctors take it because they have access to it. And then bad prognosis is predicted by the anesthetics because they find she has no breathing, she has no blood pressure, she has nothing. Why do you think she is going to survive? But what we did was that all these cases completely survived. They are all brilliant, beautiful lady doctors today because phenobarbital, you know, they take 100 tablets, 80 tablets each one of them. And the tablet is so small, it's easy, it's smaller than an idli, so you can swallow an idli. You know, And it's a troublesome phenomenon. I have seen so many cases. They present just like brain death. But then you ventilate them, you give them oxygen, you give vasopressor drugs, give them IV fluids, and they recover completely with various EEG changes which you are familiar with. Now, when they recover also, this will be the physical sign of dissociated eye movements with good pupillary reaction. So that's why I'm mentioning this point. Completely, but they will have signs of brain death on the table, but they will recover completely if it's metabolic. That's why in brain death definition itself they say they should not be metabolic or drug induced or hypothermia. Hypothermia, metabolism, drug induced should be excluded before you call it a brain death because of certain neurological findings. That's a message of this case. Now, this is a very interesting case. This man was, the advantage of old age is that the patient is also old and you are also old, and he remembers that you have seen him 20 years back. Dr. Lakshmipathy once introduced me to a very big audience, API audience in Chennai. I think Varulraj will remember, where the Mangalore doctor who is a controversial doctor, Hegde, Monapa Hegde was there, T.K. Ganesan was there. We were all together, each one trying to embrace the other. And Lakshmipathy came from that distance and said, Dr. K.S., do you know them? I said, I know them very well. They all, Arulraj was also there. And then the API at Chennai. And then they said, I know him very, very good. Then Lakshmipathy said, I also know him. He's a very old friend. How do you say he's a very old friend? He said he was very old even when he was admitted in medical college in 1951. We were classmates. So that's how he definitely defined old age. But anyway, looking old or young is not the point. Something inside the skull is more important. Now, you can see here, this man has seen me 10 years ago, and then now I find him coming with the same story of chronic headaches, but his headaches used to get relieved by coffee or some paracetamol, so it was not a big problem. But when you examine him, you find large temporal arteries here, clinically. You can see here the temporal artery here. Now, I showed it to many neurologists in Madurai. They said it's temporal arteritis. So I told them, look, that's why he has got headaches. Then what do you want me to do? You must do a biopsy. That's answer given to me by the neurologist. I said, I have not done a biopsy 10 years ago. Why should I do it now? He is quite well. He is earning his livelihood. He is an active member of the family, head of the family. There's no problem. Why should we disable him by neurology? So, and then when you touch it, there is no tenderness. It's pulsatile, not tender. And what I learnt here was, his skull was warm skull and non-tender temporal artery. And this is a diagnosis here, that's Paget's disease. What I learned was that Paget's disease can be chronic headaches. They will earn their livelihood normally until they come to a neurologist, but they will be normal. And then you find here that you should not do a temporal artery biopsy even in temporal arteries because they are all collaterals. His angiogram, I did an MR angiogram on him. He has very large external carotid artery branches. They are all waiting to supply to him in case some brain vessel gets blocked. They will go and supply. They have got excellent collaterals from the external carotid to internal carotid through the ophthalmic artery. We should not do a biopsy here and remove that collateral for tomorrow's mistakes. So I think this man has a Paget's disease without any treatment for 10 years. He has no problems. But next case, this was also published in BMJ recently. 72-year-old man, published by an endocrinologist from Kerala. Same story, large L, headaches, warm skull, no bruit in this case, calcium, phosphorus, vitamin D, parathermone, all normal. So we are not missing any other form of metabolic bone disease or endocrine bone disease. But alkaline phosphatase is raised as in our case. But they treated him with alendronate, biphosphonates, calcium and vitamin D. In 6 months, the alkaline phosphatase is reduced, but patient did not get better. He continued to have headaches and his deafness and scalp vessels were same. It can produce deafness, it can produce blindness because of optic nerve pressure, mechanical pressure, even a paraplegia, you can decompress them and make them better temporarily, provided it's not irreversible. But that's X-ray showing typical pages. Now, the point is, there are many cases, because of our old age, we know we have done nothing and they are doing much better than if you have done something. And you should be able to distinguish that. And even any vitamin B complex tablets helps them, and they think they are better because of that. This is Paget's warm skull, and the message is, I'll tell you the message later on. This is about calcium metabolism, and I don't want to bore you with that. Tetany is caused by calcium hypokalemia due to metabolic alkalosis or respiratory alkalosis, or hypocalcemia or rickets, or whatever you call it, hypoparathyroidism also. And best investigation is electrocardiogram, because laboratories are unreliable. It is difficult to show hypocalcemia in the laboratory easily. It's difficult. That's hypocalcemia. ECG is prolonged QT interval and prolonged ST also. I think you're all very familiar. And now you can see, if you do the calcium, phosphorus and parathermone levels, you can diagnose all these conditions. Chronic renal failure, vitamin D deficiency, and alkalosis, metabolic and respiratory. All of them produce calcium, phosphorus deposition. Parathermone will be normal in metabolic alkalosis, but they may be abnormal in chronic renal failure, vitamin D. So I think these are all very easily done. There is no point in doing brain scans and MRIs and various other things we do always to do this. And then here, rickets, myeloma, sarcoid, Paget's, osteosclerosis, all of them can be diagnosed by calcium and phosphorus investigation, just as we diagnosed all metabolic myopathies with knee-jerk and creatic phosphokinase. You need a reliable neurologist and a reliable laboratory, that's all. I will not go into it. And you can reproduce the tetany by mild ischemia by a BP apparatus between systolic and diastolic. Keep it for 5 minutes or 2 minutes. You can get the tetany like this, as in this case. Sorry. I'm sorry. Okay. I will not bore you with more of verbal neurology. I'll give you some visual neurology. And that's, you see, plain X-rays is enough. You can see the Paget's plain X-ray and Paget's and it's called basilar impression. That's called basilar impression, where there is no angle between anterior cranial fossa and posterior cranial fossa. Usually it will be like this. Anterior cranial fossa, it will be like this. Here it's all a straight line because the upper cervical spine has gone into the brain. You can see here, upper cervical brain spine has gone into the brain. That's what happens in Paget's disease also, but this was a congenital basilar invagination, like congenital atlantaxial dislocation. Very interesting point I'll tell you in Chennai. Now, Dr. Ramurthy and other neurosurgeons used to operate on them because they come to you with bulbar palsy, dysarthria, sometimes hemianopia, and difficulty in walking. And I was arguing with Dr. Ramurthy with a common sense. I told him, sir, this is a congenital condition. You are an acquired neurosurgeon. How do you want to correct it? He laughed. I said, you are an intelligent talk, but tell me, this is nonsense. This fellow is suffering, I have to decompress him. It's compressing his nervous system here. What are you talking? You are a physician, you will only talk like this. So he said, sir, just think about this. So he operated, when some of them died, some of them survived. Then he agreed with me, what do you want me to do now? I said, sir, he is living happily with this, carrying head loads, mother of 4 children. He has no problem, sir. Why do you want to operate on him? No, tomorrow he will become tetraplegic, he will die. But he died on the table. So I said, okay, what do you want me to do? Sir, give me 10 cases who refuse surgery. You take up 10 cases who are willing for surgery. Let us follow up for 10 years. Let us come to a decision, sir. But he, very, very, very nice man. Instead of other chiefs who will ask you to get out if you talk against them, he said, come in. Now tell me what you want me to do. Huh? So we followed 10 cases like this for 10 years. Those who refused surgery were medical problems. Those who agreed for surgery became surgical problems. Same disease. Same disease. Same disease. And my patients, 6 out of 10 survived. His patients, 7 out of 10 died. So we concluded both are good for a small number. The conclusion is more important. Both are good for 8 people, but good for 3 people. So we reached a compromise and took our usual coffee. No problem. But all this is because I worked with the surgeons. I worked with neurosurgeons. Morning, afternoon I will be in the theatre helping them to assist neurosurgery. Then I became a surgeon myself because I will come late or go early. Raja, niye pathaga, niye close pannu, niye mood. You become a neurosurgeon, unqualified neurosurgeon, but useful neurosurgeon. Useful to the patient and to the doctors. And I also supply them coffee vadai to make you more friendly. And that's how you have to learn. And when surgeons and physicians have to live together, why not cardiology, neurology and general physician live together? It's a catastrophe separating all these super specialties. Catastrophe for the patient, but increasing back balance for us. I think, can someone guess a diagnosis? This was a young lady with hypertension and her BP was 170 by 110. I was recording the BP. As she was recording the BP, she developed tetany. Her chemistry was like this. As she had a metabolic alkalosis, metabolic alkalosis with some calcium phosphorus was normal, but her sodium was very high, potassium was very low. Potassium is low, even for a bad laboratory, it was very low, but sodium was high. Her blood pressure was 180 by 110, and she develops tetany on tying the BP apparatus. Now the diagnosis is Conn syndrome, occurs more in women. Don't worry about the small scar here. That was done for some lymph node biopsy, not parathyroid surgery. Forget about this. That scar is nothing to do with that. But if you make up the scar, your observation is good. Now, this is Conn syndrome. Metabolic alkalosis producing tetany in hyperaldosteronism. The adrenal cortex has 3 layers: zona glomerulosa, fasciculata, and reticulosa. Glomerulosa is the one that has mineralocorticoids. Now, this lady is very interesting. She was wandering in the streets of SS Colony behind my clinic, and was picked up by her relatives and brought to me. She is a very highly educated social worker. She has gone to Chennai and has been doing some social work, and without proper food and drink, vegetarian, but she did not take proper food, or she was not a diabetic. She was nutritionally deprived due to her occupation, and she develops abnormal behavior and some ophthalmoplegia and so on. So neurologists in Chennai saw her, and they did as usual, more interested in radiology than neurology, and did a scan, and they found she had some bleeding near the thalamus. These are the neurologists who have come straight from the medical college to the corporate hospital and call themselves professors, and without adequate experience. They said it's a stroke. Treated as a stroke. She came to Madurai, and it is very obvious this is a case of Wernicke-Korsakoff syndrome, beautifully described in textbooks by B1 deficiency. They could have given, no, I have never seen a brain hemorrhage in this area due to trauma or due to any other cause, due to any hematological cause. Only vitamin B1 will cause a hemorrhage in this area, near the mammillary bodies and the medial thalamus. We teach the students, if you find in hypertensive, 200 by 110 is a brain hemorrhage, the hemorrhage should be in the pons, or it should be in the basal ganglia, or a cerebellum. If it is somewhere else in the brain, don't blame hypertension. It must be amyloid angiopathy or a metastasis or some other problem. These are all things you can never disprove, even if you are a PhD, FRCP and so on. They are written by our forefathers after enormous experience. We can't change it today. So similarly, if you find a hemorrhage somewhere here, This is due to B1. Nobody knows why B1 deficiency should cause a hemorrhage here. But it clears by giving vitamin B1 100 milligrams IV for 2 or 3 days. That's all. You don't need a neurosurgeon to operate on that. And you can see that's if you miss the diagnosis in the life, you can meet it post-mortem in the bottle. That's post-mortem in the bottle. Those who miss during neurology can go to pathology and have a confirmation. And the fundus, see, completely clears up. You get so much of hemorrhage in Wernicke's encephalopathy, it completely clears up with treatment. Now, in the fundus, if you find abnormal retinopathy, which is reversing, it can never be diabetes. In diabetes, even though I tell all diabetologists, they never improve the patient. They only prevent him from dying earlier tomorrow. You cannot reverse anything you have in diabetes. I don't think there is, except the blood sugar, you can bring it down by insulin. But you can't develop the neurology by it. I'll keep myself to neurology. Same with any specialty. But anyway, whereas in hypertension, if you make a diagnosis today, you can reverse it. The retinal phases in hypertensive retinopathy can reverse, even from grade 3 to grade 2. In diabetes, you can't. But here, in metabolic retinopathy, you can reverse it by giving IV B1. Now, look at the title. That's why you should read old textbooks and not modern internet. Polioencephalitica hemorrhagica superioris. That's a wonderful. Polio means grey matter, not white matter. So grey matter is affected. Encephalitis affects the brain. So the brain grey matter is affected. Hemorrhagica, it's a hemorrhage. Thalamic, medial thalamus is a grey matter, hemorrhage. Superioris, this is called superior in neurology, and pons is called inferior. Called superior ophthalmoplegia and inferior ophthalmoplegia. So this title itself tells you the diagnosis. And you can say whether the boy has read the book or not by showing this title. And then it's clinically described beautiful amnesic confabulatory psychosis. These people will be amnesic, recent memory is totally damaged. Confabulatory, doctor morning vandingaley enna marandittingala neenga அப்படிம்பாங்க வந்துட்டு போனீங்களா டாக்டர் நீங்கள் மறந்துட்டீங்களா you would have never made a morning rounds. I said thank you very much, tell this to my chief. I came in the morning. Bad diagnosis but good prognosis. Now, and psychosis. So they can't, wonderful, I am telling you, older textbooks will give you this. Modern textbooks don't give you this. So the entire diagnosis is there. Amnesic confabulatory psychosis due to polioencephalitica hemorrhagica superioris. That is cured by vitamin B1. If you give too much of it, nothing will happen because it will go in the urine. And the British neurologist one day in the toilet said, you Indians are very good because you can color the toilets always. I said, why are you saying this? Because you give hundreds of milligrams of B12 and B complex in India, I said. Don't worry, sir, we can also clean the toilets. Now, I'll come back to the same story. If your memory is good, you can answer this. 20-year-old girl became unresponsive while traveling in the car next to her father. She was limp, flaccid, with shallow respiration. Very healthy lady. The father is there by the side so that he is completely protected financially and not socially. She was outside the house all the time. She was limp, flaccid, shallow respiration. Respiratory paralysis, and her blood pressure is very low. Pupils normal and reactive. So I have told you the message earlier lecture. If pupils are normal and reactive, it should be metabolic, may not be structural coma. And you find, but the extraocular movement does dissociate. That is, there was a internuclear ophthalmoplegia-like picture. One eye is moving on its own, other eye is moving on its own. That is dissociate. And caloric test. So, okay. EEG showed diffuse slowing, in fact, with a lot of fast activity. So this gives a clue. If you find somebody unconscious with EEG showing fast activity, plenty, that means she is still alive. She is not brain dead. And although she has other features like hypotension, respiratory palsy, etc. This is, of course, phenobarbital poisoning. And they said nothing has happened, she is a very good girl. Ask somebody to search her pillow, and under the pillow there was a bottle with phenobarbital. That is the process. And recovered completely. I think I'll stop with this. One second, let me see any more. One second. Okay. So the next lecture. Yes, thank you.
Comments or questions, we will conclude this session.
Yes.
We will move on to the next session.
Thank you, Dr. Dhanushkodi and Dr. Srinivasan. We move on to the next session. I call upon Dr. Rajan and Dr. Aarti Kannan as chairpersons for the next session, and they will introduce the speakers.
So neurology and diabetic food is always very complicated, you know. One of the worst complications of diabetes is the diabetic due to neurology, peripheral neuropathy. Sarve is always very fond of diabetes and diabetic food, and he is one among the stalwart of diabetes in India. Over to you, sir.
Thank you for kind words. All people were so far presenting cases instantaneous. They saw the patient, they treated, whether they improved or not, they go to next case. But I am going to present a case of type 2 diabetes. I am following this patient for the 20 years. How a patient with a diabetic neuropathy suffers. You so all must know, and I will give some important clues for practice for the postgraduate students, and some clues to how to prevent the diabetic foot ulcers. Patient name is Muthumalai. He is age 68 years old, type 2 diabetes, already 20 years when he came to me. Smoker, non-alcoholic, hypertensive. He is a landlord, one boy and one daughter. He is on oral anti-diabetic drugs and anti-hypertensive medications. When he came, he had already coronary artery disease, for which angioplasty done at Madurai Meenakshi Mission Hospital. And first time he got admitted on 2014, that is November, and discharged again on 28 November for type 2 diabetes, and he had ischemic heart disease and accelerated hypertension. BP was 200 by 110, and random blood sugar was 201, urea creatinine were normal, total cholesterol was little bit raised, and ECG was also regular, normal. Patient treated with bed rest, IV diuretic, cilnidipine, telmisartan, antiplatelets, and statin. Again patient treated second time, admitted on 2/2/2005 for slurred pitch. This time he came for neurological complications and weakness of right upper limb and lower limb since morning. Was conscious, BP 190 by 100, and CT brain was normal. Again treated with low molecular heparin, insulin, antiplatelets, statins, along with the antihypertensive medication. This time also patient fully recovered and no residual motor deficit, discharged with advice to continue insulin and antihypertensive, antiplatelet and statins. Again February 2013, patient came with impetigo on the dorsum of the foot, that is right foot, along with some corn foot right. There was a numbness feet present. We made it by the monofilament as used in our clinical practice, but there is a lot of difference between monofilament and vibrometry. Even the monofilament sometimes say normal. If you use vibrometry, they already might have their perception threshold must be more than 20. You must be very careful in using monofilament. And the HbA1c 10.3, random blood sugar 190, urea 36, creatine 1.2. As Dr. K said, HbA1c is misleading in some patients because if you calculate this average, it is more than 200. Here it is 190 only. And corn food debrided and daily dressing done. And a felt pad was given to patient, and he was taught how to use felt pad. So he was discharged with advice to continue self-dressing at home. And patient developed recurrent ulcer right grade 2, that is in October 2017, and daily dressing was done. Patient, in addition to put on human mixed at that time insulin and cured. Again patient developed a serious discharge from the grade 2 wound, and again offloading was done using the felt pad and cure. Patient readmitted on March 15, 2019, this time for cellulitis right leg close to the lateral malleoli. This was very chronic ulcer, could not be healed by normal dressing. So there was a raw area, large raw area was exposed. So I asked the patient to go for a plastic surgery. So we referred to Ganga Hospital. They already underwent some investigations, and they did plastic surgery, skin transplant, and became normal, and again he came to Tuticorin. Again he was admitted on 14/10/2020. It's the longest stay in the hospital this time. And the patient came with ulcer foot, base of the grade 2, left treated with wound debridement and daily dressing along with insulin and antibiotics. As no wound discharge or smell was present, he was discharged on 25/10/2000 for self-dressing, but readmitted with a gangrene left grade 2, unfortunately, toe and a pathological fracture dislocation of the metatarsal bone on 2/11/2020. Under local anesthesia, the entire foot aspect on the solar aspect of the foot bone up to metatarsal bone was removed, and the dorsal skin was preserved and dressed. This was the grade 2 with the gangrene. Patient came. Our surgeon did the deglowing of the skin, and he repaired the wound. Daily dressing of the wound, periodic debridement done from 2/11/20 to 8/12/20. Patient developed pathological fracture of the head of a metatarsal bone 2 and auto rejected. Patient developed fluctuations in blood sugar, and continuous glucose monitoring was done using freestyle liver pro patch. This is I am projecting because of the postgraduate. You can't believe HbA1c sometimes, and also sometimes blood sugar. Since the patient is as inpatient, most of the time he went for hypoglycemia or hyperglycemia. You just see his HbA1c is only 5.9. Why he is going for these fluctuations? So we put him on the liver pro. You see there is hypoglycemia early morning. Again there is hyperglycemia after lunch. Yes, this is the graphical representation. Again, how many times patient went for hypoglycemia and hyperglycemia, this chart shows. This is the daily glucose summary for 14 days. This liver pro patch was applied on the deltoid muscle. For postgraduates, you must know about this slide. The patient most of the time is out of time in range. You see 106, 79, 56, 88. Most of the time he was either in hypoglycemia or hyperglycemia, and the time in range is 62%. Then it came to 26, 19, almost very low. Time in range is very, very important. You must keep the lower limit above 70 and upper limit below 170. In between 170 and 70 you keep, the complications are less. Most of the time you need 70% of time in range. 100% is not possible. If you keep the patient 70% time in range, then you will avoid most of the complications in patients with diabetes. Here most of the time he is out of range. Even it is only 11% time in range. Even for 14 days his time in range is out of order. So what we did to prevent this hyperglycemia, a small dose of Actrabit, short-acting insulin was applied, and to prevent this hypoglycemia, the night dose of insulin dose was reduced. So, and the patient escaped from hyperglycemia. This is the gangrene of the great toe. Surgeon removed the great toe, but still wound is very dry. You see. By the time again he wants to investigate. Minutes in the room. By the time patient wound is not satisfactorily improving, there is dislocation of the plantar and the dorsal aspect of T3. So it was decided to do angio of both lower limb. So it is a late decision, must have done earlier. But we learned by experience. On 15/12/2020, CT angio both leg done. There is severe atheromatous wall thickening with multifocal stenosis with bilateral proximal and mid-superficial femoral arteries, minimal to no flow seen in the right dorsalis pedis arteries. Flow noted in the left dorsalis pedis arteries with minimal flow in the metatarsal bone arteries. This is the CT of the film. You can see there is narrowing. Again, there is narrowing at multiple places. Narrowing at the femoral, and again, even if you come down, there is narrowing at the, even in the normal limb also he has got narrowing. Again, the picture shows narrowing of the popliteal. So, patient referred to interventional radiologist for angioplasty. Dilatation done and good flow achieved. I discussed with the interventional radiologist. Both foot shows there is a diffuse atheromatous plaque subsiding. Why do you want to do on the side of lesion? He said, where there is lesion you have to interfere. Though there are proximal lesions in the femoral and distal arteries also. A lesion close to the ulcer should be dilated. That is his argument. So we referred him to the Madurai Apollo. The interventional radiologist did his job.
Focal tight stenosis is seen in the proximal SFA with string of blood contrast going through it. Distally there is good supply. Here there is diffuse long segment stenosis which is noted. So balloon is put and this is a tight stenosis which is being opened by balloon angioplasty. You can see it being opened here. Narrowing, and this is when it gets opened.
Most of the surgical things were done by...
This is after opening, we are able to see the tight stenosis which is at the level of this point is opened up. And there is good distal flow. Distal diffuse disease has also been angioplastied.
After dilatation, the patient second toe was gangrene, almost became normal. We removed the terminal phalanx only. Now the patient is coming as OP for wound management, and now wound healing well, though the third toe terminal phalanx was removed due to gangrene, and patient is on regular follow-up. In summary, we saw a patient of chronic diabetes with neuropathy, coronary artery disease, TAA. TAA and the CAD, they stopped almost progressing, giving no symptom to the patient. But neuropathy, though advanced technologies like CGM, angioplasty, everything was done, patient has to lose his toe. But fortunate, though we are very late in doing this, because already underwent at Ganga hospital, we did it late. Patient foot is saved almost. He is able to walk with a normal foot. So in patients with diabetic neuropathy, when you see first 50% of patients come with diabetic neuropathy, they will never tell you numbness. You have to objectively, you have to make patient has got sensory loss, and you must protect the foot from being injured and open to the any infection or injuries. So neuropathy in this patient is the basic thing. Later on it is added with infection and vasculopathy, patient lost his limb. So it is a duty to diagnose neuropathy, all practicing doctors, and give better care, especially with plantar ulcers. Offloading is very, very important in this patient to give the early healing of the ulcer. Thank you very much.
Thank you, sir, for your wonderful presentations. And we know that interventional cardiologist or interventional neurologist, you are an interventional diabetologist. Almost look many things maybe, and you introduce the timing and the hypoglycemic importance and many things to us, sir. Thank you.
So why I am presenting this, most of the people attending with a bandage in the leg for very long time, especially come to us, and he will come for dressing, then he will change the doctor, then he will go to government hospital. You know the cost of this dilatation for this patient at Apollo, it is 2 lakhs. All patients they cannot afford. So people at a medical college hospital, you must develop, it is a very simple test. Angiogram is done outside only, it is done in earth scan. Any people undergo this angiography test outside, and somebody must get trained for this dilatation and do it. So most of the poor patients will be benefited instead of taxing our patients, because it is not one-time treatment, lifetime he has to come. So you have to take away his financial burden for treatment. We had a similar patient, had gangrene. Same time we did angiography. He had bilateral obstruction of the arteries. The same interventional radiology referred, he could not dilate, and he advised bypass surgery of the vessel. So patient is now at Chitrai Tirunal Medical Center Vascular Department for bypass surgery.
Thank you, sir. Now the era for interventional diabetologist.
Thank you, sir.
Thank you.
Gastroenterologist Dr. Ram Subramaniam, sir.
Is a female of 38-year-old and housewife by occupation from Thoothukudi. Her chief complaints are abdominal distension and bilateral lower limb swelling since 20 days. She was apparently normal 20 days back when she developed abdominal distension, which was insidious in onset and slowly progressive, and it involved whole abdomen which relieved on medication. And there is swelling of both limbs for 19 days, which is insidious in onset, slowly progressive, progressed to above the ankle. There is no history of any abdominal pain, vomiting, puffiness of face, or decreased frequency, and there is no significant negative history. There is a history of psychiatric illness for 10 years, for which she is taking medication. Psychiatric illness was in the form of increased anger, usage of abusive language, and she had low mood, lack of interest, concentration, and crying spells suggestive of depression. And she is diagnosed as having liver and kidney disease 6 months back. And there is no history of any diabetes, hypertension, tuberculosis, and asthma. Her personal history was her diet is mixed, and there is loss of appetite and disturbed sleep for past few years. And our bowel and bladder habits are normal. There is no added habits. And her family and menstrual history was not significant. Case summary. Here is 38-year-old female, with significant past history of psychiatric illness, mainly depression and aggressive behavior, and past history of liver and kidney disease with no significant personal or family history. Comes with chief complaints of gradual progressive abdominal distension followed by limb swelling for 20 days, likely due to chronic liver disease. General physical examination. Here is 38-year-old female, moderately built and nourished, conscious, cooperative, oriented to time, place and person. Her pulse is 78 beats per minute and regular normal rhythm and character, no radial or radiofemoral delay. Her BP is 110/70 in sitting position at right brachial artery. There is pallor and bilateral pedal pitting type of edema up to ankle. There is no icterus, clubbing or cyanosis. Systemic examination. Per abdomen examination, on inspection, her oral cavity is normal, tongue is normal, and no parotid enlargement or no lacrimal swelling. There is no spider nevi, tremors or Dupuytren's contracture. Her shape of the abdomen was globular, flanks are free, all quadrants moves equally with the respiration. Umbilicus is central and inverted. Skin is normal, there is no sinuses, nodules, dilated veins, visible pulsation or any visible peristalsis, scars or pigmentations. Her external genital is normal. Hernial orifices are intact. On palpation, there is no local rise of temperature, no tenderness, guarding or rigidity. Liver is palpable 3 cm below right costal margin in right midclavicular line, and it is round. The edge is round, smooth, firm, and moves with the respiration. The spleen is palpated 3 cm below the costal margin along the line joining the left costal margin and the perpendicular line joining the subcostal margin and the umbilicus. And it is smooth and firm, and the notch is felt and moves with the respiration. There is no other palpable organs. On percussion, liver dullness present on 5th intercostal space, and it spans around 16 cm anteriorly. Shifting dullness is present, and on for spleen percussion, Nixon method is done, and it is 12 cm. On auscultation, bowel sounds are heard and 5 per minute. No arterial bruit. Digital rectal examination is normal. System examination continued. Her CNS, CVS, and RS are unremarkable, and provisional diagnosis. Compensated chronic liver disease with signs of portal hypertension without any evidence of hepatic encephalopathy, and psychiatric illness and query kidney disease. Her investigations are as follows. She has decreased hemoglobin and platelet count. Rest of the investigations are normal, and her urine examination is positive for albumin. And ultrasonography of the abdomen shows coarse liver parenchyma, suggestive of chronic liver disease and splenomegaly, and there is free fluid in the peritoneal cavity. There is portal hypertension and hepatic venous congestion. There is mild increase in the renal parenchymal echogenicity, very early medical renal disease. These are the algorithm for asymptomatic evaluation of the transaminases. And the other investigation, here the HCV antibody and HBCAG are normal, and we follow next the investigation this serum ceruloplasmin, which is normal in this case patient, and serum copper was also normal, and the 24-hour urine copper which is elevated, it is 172 microgram per day. Usually it will be less than 80, and more than 80 is usually abnormal. And the ferritin is normal, and total iron binding capacity is normal, and we screen for autoimmune hepatitis, and the markers are negative. We did a CT abdomen. It showed multiple perisplenic and perigastric collaterals suggestive of portal hypertension, and the liver biopsy was done. Liver biopsy, we found chronic hepatitis with micronodular cirrhosis, activity and patchy copper deposition is found, suggestive of query metabolic Wilson disease or query autoimmune liver disease. As the urine copper has increased, we kept a diagnosis of Wilson disease for this patient, and the esophagogastroduodenoscopy is normal for this patient. Final diagnosis: decompensated liver disease, liver cirrhosis causing portal hypertension, and there is thrombocytopenia, normochromic normocytic anemia, hypersplenism and hypoalbuminemia with psychiatric illness with no signs of any hepatic encephalopathy, and the cause is Wilson disease, child classification class B, and there is chronic kidney disease stage 4. Thank you, sir. Thank you.
Town and friends and my dear postgraduates. Avoided had we evaluated her earlier. So this is one particular problem which goes to multiple OPDs in a medical college. They can present to psychiatrists, they can present to neurology OP, they can present to orthopedic OP because of deformities in the limbs, etc. And they can also come to gastro OP. So this is a multi-system disorder, and it is preventable. If you diagnose early and start treating her, she could have avoided all this. So that is the only reason why I wanted to present this. And now patient is waiting outside. Can you just bring her? After starting her on, see, one problem here was we did find till liver biopsy, and till liver biopsy also it is inconclusive whether it is autoimmune hepatitis or Wilson's disease. But anti-nuclear antibody was negative, urine copper was elevated. I don't know why, but we get to see here a lot of overlap syndromes with autoimmune hepatitis and Wilson's disease. We have cases which were ANA positive and urine copper is highly elevated, and liver biopsy shows either Wilson or autoimmune. So sometimes we have to put them on steroids because most of them will have active hepatitis. And this lady, she is the patient here, and she is absolutely now normal except for stigma of liver disease. All her psychiatric symptoms are better controlled with reduced dose of antipsychotics after starting D-penicillamine. Now she was, the last time when she came, she was asking me whether I can go and join my husband and see my children. She's improved that much. So this is the thing, we have to always, whenever any case of chronic liver disease, especially women who come, we have to evaluate them for autoimmune hepatitis and Wilson's disease. We have to look for KF ring. For her, KF ring was negative. But ultimate diagnosis was urine copper and biopsy. And if it is not having any ascites, all cases of chronic liver disease, we do biopsy. And biopsy, again, the problem is you should have a good hepatopathologist for studying the biopsy samples. So that is the dilemma we have. But now she is totally improved, even her ascites, everything has come down, and she is otherwise normal. She is on D-penicillamine. Again, the drug is a bit difficult to obtain now, but she is getting it, and she is improving well. So that is the idea of presenting this case. And almost every OP will, specialty OP will see these. We will have to have this in mind whenever we see a similar case. I don't want to go into pathology and other things of Wilson's. I'll be happy to hear Professor KS about this.
No, very illustrative case and exciting case. I think we have learned more than making any comments about this. Of course, we see large number, hundreds of cases of Wilson's disease, enormous research work on the neurology of Wilson's. Of course, we never diagnose Wilson's without KF ring, but that's only for neurological Wilson's. Wilson's can present as pure neurology, as pure hepatology, or pure nephrology. It can affect all the three organs and damage them, but KF ring is only seen in neurological Wilson's, and therefore we may completely miss it. As you said, ceruloplasmin is normal, and what about serum copper? Serum copper is low.
Normal, sir. But sir, what we do is urine copper is elevated. So we normally what we do is once we start these patients on D-penicillamine, we again measure the urine copper. So if they come back to normal range, means that it's a therapeutic challenge.
In Madurai, we have done a few liver biopsies and showed the liver copper we have got measurements for this. You need a particular preservative. Liver copper is always increased if you think it is due to Wilson's. Liver biopsy can be stained for copper.
Yes, sir, but copper stains can be seen even in autoimmune hepatitis, primary biliary cirrhosis, and Wilson's in liver biopsy.
No, it's
so
amount
per
of,
weight
amount of
of
copper, yes.
Yeah.
For 100 grams, we
of
have
liver,
limit.
you have to measure the copper.
We did this in Madurai for a few cases.
CMC Vellore only is doing, sir. Nowhere else they do now.
You need a
Normally,
particular
I send
preservative.
all the liver biopsies from here to Reela Hospital, previously Global, because we have a good hepatopathologist who does it as a concessional rate from a medical college.
And more than that, you have proved by giving penicillamine there is some improvement. That itself is therapeutic diagnosis is there more than anatomical diagnosis. I think that's good. I will show a case of typical portal systemic encephalopathy to supplement your presentation. Thank you.
Sir, again, there are two things, sir. Okay, that he is going to present one more case, just 5 minutes, because sir was telling about this. Let him present the other case also.
Please, please.
Years-old female, housewife by occupation, came with chief complaints of abdominal distension since 3 months, swelling of both legs and feet since 3 months, passage of black color stool since 1 week, and altered sensorium since 1 day. History of present illness. She was almost normal until 3 months back. Then she started developing abdominal distension, which was insidious in onset and gradually progressed. She developed a swelling of feet, initially swelling of feet followed by legs, which was insidious in onset and gradually progressed. She was having melena since 1 week and drowsiness since 1 day with decreased level of consciousness and not responding to verbal commands. Patient has history of hypersomnia, reversal of normal sleep pattern, disturbed consciousness and irritability. No other significant positive history. Past history, she was diagnosed with chronic liver disease 1 year back, but she was not on follow-up or on any medication. Personal history. There was loss of appetite since 3 months and altered sleep pattern. No history of any diabetes or hypertension. Family history, no similar history in the family. General examination, she was having a pallor and recurrence along with altered consciousness level. Vitals. Her systolic blood pressure is a bit low. Rest of them are normal. Systemic examination, CVS and respiratory system is unremarkable. Per abdomen, it is distended globular with shifting dullness. Central nervous system examination. Patient was drowsy, disoriented, incoherent. Sensory system examination could not be done. Motor system, there was hypotonia, hyperreflexia in all limbs, and power could not be examined. Asterisk 6 is present. Plantar response is flexor bilaterally. Provisional diagnosis: decompensated chronic liver disease with portal hypertension, variceal bleed, ascites, jaundice, and hepatic encephalopathy grade 3. Differential diagnosis: metabolic encephalopathy like uremia, hypoglycemia, hypoxia, any electrolyte imbalance, or toxic encephalopathy, any intracranial events. Investigations: she was having anemia and low platelet count. Urine examination was normal. Biochemistry, her RFT are normal, electrolytes are normal. LFT, there was hyperbilirubinemia along with low albumin and reversal of ABG ratio. Viral markers are negative. INR was elevated 1.8. Chest X-rays was normal. Acidic fluid analysis, there was a SAG was 1.7, indicative of transudate, and there was no evidence of SBP, and culture is negative. Ultrasound abdomen, there was evidence of chronic liver disease, portal hypertension, ascites, and splenomegaly. Upper GI endoscopy, there was 3 columns of grade 3 varices in distal 8 centimeters of esophagus, along with mild portal hypertensive gastropathy, and EVL was done on the same day, that is 16th of this month. Final diagnosis was decompensated chronic liver disease with portal hypertension, esophageal varices, and EVL was done. Ascites, jaundice, hepatic encephalopathy grade 3. In management, nasogastric tube insertion was done on the day of admission, that is 13th of this month. Syrup lactulose bowel wash, rifaximin, and injection ceftriaxone started. Injection octreotide was started because of suspicion of variceal bleed, as she was having melena since past 1 week, and 3 units of human albumin was started. Injection vitamin K, 10 mg IV OD was started. Over the next 2 days, patient improved clinically from hepatic encephalopathy. She became conscious, oriented, and coherent. On 16th of this month, upper GI endoscopy followed by EVL was done. In this patient, variceal bleed leading to catabolism of blood in the intestine and increased absorption of ammonia is most likely the precipitating factor of hepatic encephalopathy. Usually the most common precipitating factors for hepatic encephalopathy are infection. Next is electrolyte imbalance, followed by constipation and upper GI bleed. And in this patient, the most probably the precipitating event was upper GI bleed.
I think you missed out one very important cause for hepatic encephalopathy is abuse of diuretics and NSAIDs. Most of the time, like when they call me for examining a case with hepatic encephalopathy anywhere, first thing I do is stop all diuretics and don't use diuretics. I write it in bold letters in all the prescriptions. Because what I find is most of them will have massive ascites, and immediately they give intravenous either furosemide or torsemide, and that will be the reason why these people go for hepatic encephalopathy. Second thing is, whenever you put a patient on diuretics, you have to call them at least every 2 weeks. Ideally, I call them every week and measure their weight. And if they are losing more than 1 kg per week, generally I try to reduce the dose of diuretics. And maximum, I try to avoid writing diuretics for any patient, even with moderate ascites. I always try to, massive ascites, I call them, I do a large volume parasynthesis, give them human albumin, and most other them they'll become better with this. And you can keep them calling every 2 months or so for a dose of human albumin. In GH, what we do is, I've done a study on, because human albumin is very costly and it is not available most of the time. What I do is I give them cryo-poor plasma. That is plasma from which cryo has been removed. Most of them, they don't use that product in the blood bank. I know our blood bank medical officer is not here. We had a deal. Always, every day she used to send me 10 or 15 bottles of cryo-poor plasma to my ward. And all the ascitic patients, they'll be receiving 1 bottle each every day, minimum for 5 days. And I find that in GH it is free. And I find the effect of cryo-poor plasma is as good as human albumin, 20% human albumin. That is one thing. Second thing, for postgraduates, there are 2 types of hepatic encephalopathy. This is portosystemic encephalopathy, where there is a shunting of blood from the portal circulation to the systemic circulation in cirrhosis. The other one you get in fulminant hepatitis, where there is hepatic encephalopathy due to high bilirubin, and the only differentiating factor is papilledema, which is normally not seen in portosystemic encephalopathy. So that you should be careful. A severe jaundice patient coming to you with encephalopathy could be non-portosystemic encephalopathy also. So the only differentiating factor is papilledema. Second thing is in this patient they have done a variceal banding. So normally in this setting I will hesitate to do a banding, because if the INR is more than 1.5, generally I avoid doing banding, because this patient is definitely not going to die because of bleed. You can always treat the bleeding with FFP and blood, etc., octreotide, somatostatin. There are so many drugs available. But if the patient develops post-EVL ulcer bleed after 1 week, it will never respond to anything but stenting or normally we inject not sclerosins. No. Glue can be done, but the powder is there, no spray. Huh? Not eternal. What is the name? I'm getting nominal as they say. Collagen spray. Okay, only that will be useful. Otherwise, post-tibial bleed, I have lost quite a lot of patients in the earlier times. So nowadays, even for an alcoholic hepatitis with very high bilirubin who comes to me with history of melena, I try to avoid doing an endoscopy because I am not going to intervene. So these patients you can jolly well treat, make the bilirubin come back to normal, give FFP and try to bring the INR back to normal range, near normal range before intervening for a varicose bleed. Because most of the time they will never die of varicose bleed. So normally I try to avoid doing varicose banding in this setting. I'll have to bring the INR below 1.5 for doing it. Because in the guidelines for treatment of alcoholic hepatitis also, acute fulminant hepatitis in alcoholic, they say avoid doing a upper GI endoscopy. So we will not normally do that. Thank you.
Thank you, sir. Thank you for your excellent presentations. One is, on the other hand, the Wilson's, very difficult to diagnose. And the next one is the varieties of encephalopathies and a lot of practical tips you have given. Thank you, sir.
On to protect patient and doctor, not cart before horse. I call upon Dr. Vimla Paul ma'am to chair this session.
Everybody must be nearing hypoglycemia now. So we are now going to have a short session so that we can go for lunch after that, after the valedictory function. And another title which was given is to protect patient and doctor, not cart before the horse. So this baffled me also, just as Dr. Dhanuskodi was telling about his title. So not cart before horse is a known phrase. From Cicero's time it is known. Normally we think of the horse in front and the cart or the carriage behind. So the horse will carry the cart. But here he says not cart before the horse. And the first thing is to protect the patient and doctor. So I presumed that today we have to give importance to the doctor. All along we sacrificed our lives and looked after our patients. And today we have to look after ourselves also. I don't know what Professor Srinivasan will interpret this phrase as. Over to you, sir.
No, sometimes the blood sugar is low because he is starving, not because of various causes of hypoglycemia we are aware of. And so I think I'll tell you one anecdote before that. A lady doctor had some problem, repeated vomiting, and unmarried lady doctor, and they made a very extensive investigation, or a neurologist, brain scans, gastroenterologist, and scopes. Ultimately, pregnancy was diagnosed after laparotomy, and which a grandmother would have done by saying that she missed her periods. So we don't know only about menstrual periods in our, because for us they all are complicated disorders. This happened in a medical college. I can't say the name. So I think that's what I mean. Don't put the cart before the horse. Basic things must be checked first. Any woman, I think we should ask for menstrual history. That's why we call it as LMP in the X-ray form. But nobody knows what is LMP nowadays. It's last menstrual period. So very simple things. Similarly, okay, I'll go through that, and let me come back to that problem later on. A patient was brought to me with severe papilledema and taken straight to the neurosurgeon, bypassing the neurologist, saying that papilledema means brain tumor, so neurosurgeon only should see. The neurosurgeon tried to do an angiogram on her, and I actually said, "Can I have a look?" I said, "No, you're a neurologist. Papilla edema should be seen by a neurosurgeon." This is what all senior MD doctors said. Then I said, I stood aside. The neurosurgeon put a needle in the carotid for doing an angiogram. She collapsed on the table. The neurosurgeon said, "I've never seen a case collapsing after angiogram. This must be neurology." So they called me. I took the blood pressure, was very high, 180 by 110. So somewhere somebody has not taken the blood pressure or ignored it. So I thought, you should not put the cart before the horse. I think you must take the blood pressure first, look at the patient before you think of brain investigations. Very simple, but it is happened in medical colleges. And there are many examples like this. Now, this condition, Sneddon syndrome, is... Thank you. Hello? Yes. This is an antiphospholipid antibody syndrome. Very important because you have multiple small strokes leading on to dementia. Even in diabetes and hypertension, the brain is always riddled with holes. In most diabetics and most hypertensives, they are called lacunar strokes. These lacunar strokes are so small. The commonest cause of a lacunar stroke is diabetes and hypertension, not atheroma alone. And they produce very little symptoms or no symptoms. But many holes in the brain can lead to dementia, which we call as vascular dementia. But we should try to demonstrate this before they develop dementia or before the doctor gets demented. I think we should do it all early. Now, the Sneddon syndrome is one like this, where you have many holes in the brain, but may take a long time to produce vascular dementia. But this is caused by antiphospholipid antibody mainly. They are called minor ischemic strokes, but it's diagnosed by a dermatology problem called livedo reticularis. I'll show you the slide later on. And you see the antiphospholipid antibody binds to the platelets and endothelium and causes thrombosis after vasospasm. Now, it's seen in SLE, Sjogren's, Behçet's, rheumatoid arthritis in an older age. But in lupus erythematosus, you have got both lupus anticoagulant and APLA. Then it is called secondary APLA. Primary APLA, you see mostly these APLA antibodies. Treatment is with antiplatelets and anticoagulation. It's just a multiple strokes, as in a diabetes or hypertension. But the brain CT scan looks normal. MRI shows some lacunes. Sorry. Then next. Thank you. That's livedo reticularis, where you find enlarged capillaries and venules in the skin in the reticular pattern. And you know the differential diagnosis if you are shown this picture in neurology. Panarteritis is periarteritis nodosa, polyarteritis nodosa, APLA syndrome, systemic lupus erythematosus, Sneddon syndrome, hyperhomocystinuria, cryoglobulinemia, after amantadine. All of them produce this skin change, and the skin change should alert the neurologist for some neurological diagnosis. Next one. Thank you. Now this is a very interesting condition. I diagnosed this by testicular biopsy. I don't think we should do it nowadays. This was very many years ago. This is another case. You can see two blood vessels here. Sorry. It's okay. It's the wrong side. The three blood vessels. This one, this one, this one. All of them are totally occluded by vasculitis involving the intima, media and adventitia. That's why it's called panarteritis. It's actually panarteritis nodosa rather than periarteritis nodosa. Periarteritis, vasculitis and endoarteritis all together, they close the vessel. Now, I saw a patient with a foot drop some years ago, and I forgot about him because he recovered his steroids. He was very young at that time. ESR was raised. He didn't have any other problem. So since he recovered, I didn't do any further investigation, nor was he willing to spend more money having recovered from foot drop. Then he went to a top nephrologist for some problem in passing urine, And he did some tests and he found some congenitally double ureter and he wanted a laparotomy. And then he found in his pocket a slip given by me that he had a foot drop and I have treated him. So he sent him back to me. He is refusing to have abdominal surgery. Why don't you have a look at him? Then I have forgotten about him. Then I looked at him, but then a few days later he developed a chest pain. It was a pleural rub and there was a small pericarditis. So it struck to me, connecting the testis with the high ESR and the pericardial rub. His ESR was high. It was pancreatitis nodosa. Testicular biopsy was done in those days, because why testicle? Because testicle is the most vascular organ. You can do a sural nerve biopsy and take a blood vessel and call it sural nerve if you are a bad pathologist. But testicular biopsy, you can't miss a vessel. It's fully blood vessel. So I did, but it's not done nowadays, but because I have got various rheumatological investigations for periarthritis, and it was, you can see the complete vasculitis. So he improved with steroids and so on. Now, panarthritis is one condition in which you get livedo reticularis, or the skin changes of. Thank you. Now, I'm glad I'm following the gastroenterologist, because there's a lot of gastroenterology in my slides also. This is a very interesting condition, celiac disease, because it's like mitochondrial disease. It affects many organs. It can affect the bowel, it can affect the peripheral nerve, it can affect the cerebellum, it can affect the entire brain axis due to vitamin E deficiency or due to malabsorption and fat-soluble vitamin deficiency like ADEK, whatever it is. And you find in earlier days we had a lot of publication in Bombay on tropical sprue and peripheral neuropathy, and a lot of work has been done in Chandigarh also, experimental animals and human beings and so on. But all of them are supposed to be due to gluten sensitivity. Gluten is a protein. It is present in rice also, but much more so as gliadin in wheat, rye, small amount in oats, etc. But what is present in wheat and rye are harmful to us, but what is present in rice and oats, etc., are very small and not harmful for consumption. And this exists in India. I think we had this discussion last time in the same hall about gluten, and Ramasubramanian perhaps remembers that. And in Delhi they have done a test on antibodies to gluten, not only gliadin antibodies but all the other antibodies specific, and 20% have got this even in India, which is very high in the United States. Now they feel with the fad for fat, many people in the US, especially women, take fat-free diet and become thin to be thin, beautiful girls, and become ugly later on. Now the result is, when middle-aged and old people also take this, remove the fat totally and take fully carbohydrates, then they develop a dementia due to gluten. And this is called as wheat belly syndrome. One doctor wrote big books on wheat belly syndrome in the United States, all caused by high carbohydrate diet and a low fat diet, and because of the high incidence of gluten sensitivity in the United States. And now they call it a type 3 diabetes, because these people develop Alzheimer's disease very early. Alzheimer's disease itself is called presenile dementia. These people are pre-senile and actually juvenile. They get diabetes in that age, of a type 2 diabetes in a younger age, like Modi's type 2. And they develop Alzheimer's disease very early. And if you just remove the gluten from the diet, their dementia improves. Brain gets better. Not by giving vitamin B12 or other and stimulants of the brain and so on. So I think they have established beyond doubt. And the final diagnosis comes by duodenal or jejunal biopsy to show the villous atrophy. The next few slides will show you that. So that's the subject of this talk. In other words, in our country also, a small number of people have peripheral neuropathy, cerebellar ataxia, as well as malabsorption syndrome due to gastroenterology. Due to this, and giving them vitamins or even vitamin E or other vitamin deficiencies do not correct the neurology or the gastroenterology, but it only wheat-free diet improves them. That's the purpose of this talk. Not very large number, but a small number enough to cause disrepute to a senior physician. Now, I won't go to the other. This is a major message. And then you can see here, it can also cause a calcification like this in the occipital lobes, like the Sturge-Weber syndrome, where this Sturge-Weber syndrome, you have facial nevus and an occipital lobe calcification with strokes and so on. But this calcification is associated with no brain pathology, but nobody knows why. The serum calcium is normal, parathermone is normal, alkaline phosphatase is normal. It's not a calcium disorder, but there is a calcification in the brain in these people, characteristically in gluten sensitive people. Of course, they may also have problems of celiac disease. So, celiac disease is a malabsorption syndrome, that's all. Diarrhea with loss of blood and fat-soluble vitamins. I will not go into it, it's too late. But it can resemble cerebellar ataxia. The picture here is Friedreich's ataxia. You get a knee jerk with a flexor plantar response, as you said in portal encephalopathy also. And knee jerk is present, ankle jerk is present, plantar is flexor. Plantar is extensor, but ankle jerk is absent. And you may get a heart block also, or various cardiac arrhythmias. And these people have a scoliosis, pes cavus, difficulty in walking and so on, and they have a cardiomyopathy also. This combination is very typical of Friedreich's ataxia, but it affects a different chromosome in Friedreich's ataxia, and they can have same picture with celiac disease. You give vitamin E, partly they improve, partly because vitamin E is a major mischief maker, but unless you restrict the gluten, they don't have a full improvement. Now, this is the picture. I'm sure Ramasubramanian is very familiar. There's a normal duodenum and jejunum mucosa with so many villi projecting so beautifully into the lumen to absorb food materials. This is the atrophied one, which have any absorbing surface here, but these are all deeper glands. These are the mucosal glands totally atrophied. And here you can see almost a naked eye view or a short mic. And this is a normal villus projection, and this is totally ironed out picture of the duodenal mucosa. When will you do this biopsy? You will do this biopsy if the antibodies are positive, specific antibodies for gluten disease are positive. As you can see here, 45 patients with osteomalacia, proximal myopathy, 14 had gluten neuropathy. In other words, they won't improve with calcium or vitamin D and so on unless you restrict the gluten. But they have a clinical picture of osteomalacia and proximal myopathy. Like that, there are conditions in which they don't improve even though your diagnosis of malabsorption is correct, but the cause of the malabsorption is gluten. That's the point. No small number, but I suppose sorry, sorry. Next. Previous. Okay, I think I'll show you the portal hypertension a little later on. Now we will come to this topic of abrupt falls in young and old. I think above the age of 60, 30% I believe fall. Many of them sustain fractures if their bone is already weak. But if they have been healthy earlier, they don't get fractures as many times. Like your brain also, if you have not been using it, it's already atrophied to become Alzheimer's very soon, but you have been using it or misusing it or abusing it, it's okay. The brain is all right and you won't get Alzheimer's. To avoid Alzheimer's disease, your brain should be working, not necessarily in the proper way. You can be a burglar or a thief or a cyber crime. Whatever it is, use your brain to destroy somebody or quarrel with your wife 100 times. It should be used very nicely, then your brain doesn't get atrophied. Brain does not know whether doing good or bad. It's working, that's all. You know, Bin Laden, who destroyed United States towers, in spite of great US security over New York, was working for 5 years to have his techniques to destroy New York. And ultimately he destroyed, killing 500 people. His IQ was, I believe, 170, 165, better than Nobel laureates. like Einstein or even Steve Jobs and even neurologists. So I think brain has to be used some way. Do some mischief, or read neurology or general medicine, or attend classes and collect these points. But it's not, otherwise it loses. No, I'm talking a very important point. This has been discovered by live brain research in the United States now. Today we are doing awake neurosurgery, awake surgery, awake neurology. We learned by monkeys, guinea pigs, killing them all in the student days. Now we don't kill people, but we learn from human beings whose brain is used or misused or not used. So open the skull, conscious patient, stimulate various areas, take the chemicals and learn from human brain what is wrong with the human brain. We are not transferring animal knowledge to human knowledge nowadays. It's being done every day in many places. It has been done in Madurai also. Now I think, therefore whatever I'm telling you is applicable to human brain. And many of the things that you see in the magazines are about rats and other people. I'm not transferring rat to human man. Now, similarly, in the older age, who are biologically old and neurologically also old, I mean calendar-wise also, I'm talking of such people, you find that there are many causes of fall. Some of them are cardiac, breath-holding spells, vasovagal syncope, convulsive syncope, cough syncope, micturition syncope, etc. Some are partial due to partial hypotension. And various causes of partial hypotension, I'm thinking I will not go into it. Cardiac causes like aortic, they are exertional syncopes, aortic stenosis, pulmonary embolism, and so on. Various arrhythmias as well as QTc problems. Drop attack, this is a very interesting condition. Suddenly you drop, there is no loss of consciousness, pulse and BP are normal. For some reason, it is almost hysterical. Suddenly you drop and then you get up quickly. I remember in London when two great people fought with each other and published in BMJ several articles on this subject. One was Paul Wood, the greatest cardiologist. I think all of us remember his Wood book. It's a textbook of cardiology which many of us older people with grey hair have read. The younger people only look at internet. Now, and another neurologist, Russell Brain, again a top neurologist in London. They were fighting in clinical meetings, I have seen them, as to what causes drop attacks. Is it cardiac failure or brain failure? Who controls whom, brain or heart? By which way? And this sort of thing. They never reached a conclusion and both of them died, so we forgot the topic. Now, even now we do not know, but it's a very interesting condition of fall, young or old, without any loss of consciousness. They completely pick up, and they are normal neurologically otherwise. POTS is orthostatic, postural orthostatic tachycardia syndrome. Here, instead of bradycardia as in vasovagal syncope, you get tachycardia, but there is no change otherwise in blood pressure, or there is no loss of consciousness. It's not a really syncopal attack. For some reason, they fall because cardiac output is less, and therefore it doesn't sustain your muscles. In other conditions, the loss of consciousness, they fall. In this condition, they fall because of lack of cardiac output. The treatment is simpler than the diagnosis. You give them beta blocker. Mestinon is given because it increases acetylcholine, and that somehow helps the neuroconduction. I'm sorry, it's a big topic. Now, Dr. Selvaraj presented a beautiful case of diabetic neuropathy with the complications and long-term management, discovering our mistakes and the patient's mistakes. Now you will find here diabetes plus peripheral neuropathy is not diabetic neuropathy always. The common sense diagnosis is diabetic neuropathy. But neurology will tell you it can be any other form of neuropathy. And as you can see here, in a study of 103 patients with diabetic peripheral neuropathy, 53% had other proved causes. If you do all the investigations. If you only do blood sugar and HbA1c, it's diabetic neuropathy for you, it's okay. But after some time you realize they don't improve with the control of diabetes, then you realize you have got some other diagnosis. I will not go into hereditary causes, paraproteinemias, immune-mediated neuropathies, metabolic causes. There are so many causes for that, and in a medical college, we must investigate for them. Now look at this case, very simple. 65-year-old man, diabetic, smoker, alcoholic. Well, he has got all the goodness of life, he enjoys himself, and you find he has a large fibers neuropathy. This is what I mean. Pinprick is normal, touch is normal, but he has when he closes his eyes with the feet closed, he falls down. His jerks are absent. That is large fiber neuropathy. Large fiber neuropathy is posterior column, and therefore he has got Romberg sign positive, he falls down. But his sensations are normal, touch is normal, prick is normal. And when you have a large fiber neuropathy in a diabetic, which may be earlier, and then he becomes both small and large later on when you miss the diagnosis, you must consider something other than diabetic neuropathy, and that's what you find. And you find his antibodies are positive, nuclear antibodies, cellular antibodies are positive. Then you are sure, 100% sure, 100% that he is having a carcinoma lung. Let the pulmonologist say he has no problem in the lungs. Do the PET scan repeatedly or every 6 months. Cancer will show up in the lung, and you resect it. He has a complete cure of lung cancer and complete cure of neurology also. Diabetes can be taken over by diabetics because diabetes has to survive, they have to survive. And it will go on for his lifetime, no problem. And he will do well with tumor removal. So that's why I said a little bit of neurology helps you to save science and save patient also. This is a very interesting case. I will summarize this. You can use your left brain to read them, but you can hear me also. And this young man was a hotel server in Munnar, which is the border between Madurai and Theni and Kerala. Many of the Indian doctors have some estates bought in them, and so it's a tourist spot. And the hotel server was very heavily built, tall, very healthy fellow. And somebody tapped him on the shoulder one day in a joke and a small quarrel, and next day onwards he developed difficulty in breathing. What he could do was he can walk, talk, work heavily in the hotel as a server, but cannot lie down and sleep horizontally. Supine position is impossible. So he has to sleep on an easy chair, not a very good sleep, but then work very well next day. So he consulted the doctor saying, I cannot sleep horizontally. So the doctor said, I don't know, maybe since you have got nocturnal dyspnea, why don't you consult first a cardiologist? So he went to Chitra Tirunal in Cochin, and they did elaborate cardiology investigations for nocturnal dyspnea, including coronary angiogram. Nothing was positive. Stress was negative, ECG was normal, and angiograms was normal. They said it must be microangina. Come next time, we have to do a special test in coronary angiogram and so on. See, he could not afford. Then the doctor said, why did you go to the cardiologist? So you only asked me to go. I asked you to go to the pulmonologist because you have got difficulty in breathing. So go to the pulmonologist. So he went to the pulmonologist in Chitra, and they did all, the usual tests, blah, blah. And they said your arterial oxygen is normal, your spirometry is normal, FE1 is normal. So you're a normal man. So you've got some psychological problem. No, he said, no, sir, I am struggling. I am normal daytime. How can you have a nocturnal psychology? Psychiatric problems are not, they are better in the night. They can't be worse in the night, psychiatric problems. Because when you're sleeping, and all that we do as neurologists, psychiatrists, to give them sedation to sleep, to make them better, and we can sleep. So that's what, so they was not happy with the diagnosis. Then they changed the diagnosis. It's a sleep disorder. Because you are getting problem only in the night. So you got a sleep lab, you have to pay for 10,000 rupees for a one night. Any hotel is cheaper than that, but you can sleep in the hospital hotel. In the night, we will put electrodes in the heart everywhere, and we will analyze you and get, both of us can get benefited, financially or otherwise. So but he could not afford that. So he went back to the doctor and said, sir, I won't go to the hospital. Let me sleep in the sitting position. I don't want to sleep in the lying position. Now, the doctor said, sorry, I can't do anything more. Tell me one investigation they have not done so far. Cardiologists and nephro. And they say, sir, X-ray just, every time I show them, they throw it away. They don't look at it because it's not a good X-ray. But that's the only investigation they have not done. All the rest have been repeated. The doctor looked at the X-ray chest and said, yeah, this is the diagnosis. Now you go to Dr. KS, I know him very well. He can diagnose certain unusual things. Maybe you have got a very unusual problem. So he came to me and the X-ray chest was highly diagnostic. I'll show you the X-ray. This happens in a very big corporate hospital, as Arul Raj was telling yesterday. In corporate hospital, there is very little communication between the patient and the doctor. There is more communication between patient and gadgets and the financial department. And then the very little communication between the top and the bottom. I mean, house surgeons or junior doctors and the consultant. And they only meet in the crowded place called lift, where they rub on the wrong side. But otherwise they are separated widely. Wait a minute. Everything, liver function, renal function was normal, lung respiratory function was normal, etc. Okay. And now you see chest X-ray. It just gives a diagnosis. Simple thing like skull X-rays and chest X-rays, I think some of us should do it before we can afford costlier things. You can see the diaphragm is his normal chest X-ray, inspiration and expiration. Inspiration diaphragm is low, expiration, I think he's recently had his food also, his dilated stomach, and that's a normal X-ray. Lower part of the fifth rib is the usual place, it goes down. We do the tidal percussion to see the movement of the liver up and down. And this is the patient, this is the patient, they are all elevated. This is the normal X-ray, chest X-ray. I remember this because my professor used to ask me, why is the diaphragm higher on the right side? He said, because liver or because heart is heavy. Well, that's not going to it now, but anyway, they should never be equal. The right diaphragm should be higher than the left diaphragm, and then in paralysis, you find it is much higher than this. This is lower part of fifth rib, and so on. So he has got bilateral diaphragmatic palsy for some reason. Next one. That's the diagnosis for this nocturnal dyspnea. He cannot sleep on the floor or cot, but can sleep well standing or in a classroom like this, but otherwise he cannot sleep. You know, in a US study published recently, 30% of people in international conference sleep during the conference. Yes, they have published this, 30%. So don't be worried about a large audience, worry about the wake-up audience. Or 1/10 of them will be looking at cell phones or talking to somebody else. That's also, you can minus them also. You can see here, normally our diaphragm moves so much, up to 7.2 centimeters, to give us a lot of breathing space here. That's why all of our problems, our apex contributes very little to respiration. The basal portions of the lung only contribute a lot to respiration. And you find this is a picture, it shows how much our diaphragm can go down in deep inspiration and allow us to take so much of oxygen inside and give more of carbon dioxide outside. This is lost in diaphragmatic palsy. And what is the neurology of diaphragmatic palsy? Now the diaphragm is the only muscle that keeps us all awake in the night. Diaphragm is the only respiratory muscle that keeps us alive in the night, because it's the only muscle, it is not voluntary, it's involuntary, partially voluntary, daytime voluntary, nighttime it's involuntary, controlled by brain centers. In the daytime we use the intercostal muscles, external and intercostal, and move the chest outside and inside. We can breathe, over breathe, under breathe, whatever we do. We can, or laugh and smile or jiggle, dance, our chest moves very nicely. But in the night, it's a diaphragm that keeps us alive. If the diaphragm doesn't work, and you see, diaphragm has so much of ventilatory capacity. And if it doesn't work, I'm sure you will be grossly dyspneic, and therefore this man, hotel worker, cannot sleep. Simple physiology taught to us by our physiology professors and anatomy professors, but then we forget them very easily later on in life. Now, and then what I did was to do a phrenic nerve conduction in Apollo here, and that's a very simple way of doing the phrenic nerve conduction, and proved that this man has a diaphragmatic palsy. I don't know, it occurs in many conditions, including 8 to 10% of cardiothoracic open heart surgery people develop diaphragmatic palsy because they go very near the phrenic nerve here during cardiac surgery. But then they will never have any problem because the other diaphragm always looks after. When you commit a mistake, your assistant can help you to come out of trouble also. So here, there are infective polyneuropathy is affected, in diabetes is affected. I mean, any condition diaphragm is affected, but likely not both the diaphragm to the same degree, and therefore we are all safe by missing the diagnosis. Now, next one, sorry, I'll show you. The next step. Okay, thank you. Now, he improved with steroids, and I'm following him for the past 7 years, and he is absolutely well. Working heavily, fighting with people manually, with his colleagues, and also sleeping well at night and earning his. And unfortunately, he will bring all incurable cases from Kerala to me, saying Dr. KS will cure them. Terminal cases who should go to cancer homes or old age homes, this fellow will be recommending. And when I shout at him, he will bring some cashew nuts from Kerala and say, sorry sir, I will not do it hereafter. That's all he said. Now, he is still alive, very fair. But the cause was diaphragmatic palsy. It can occur due to some viral, I don't know, the cause must have been some viral infection, not due to the this is what now Dr. Krishnan Swaminathan, the endocrinologist, once presented a case in Meenakshi Mission Hospital of tetany, very nice tetany photographs, and asked the diagnosis from the audience. None of us could answer. And then we gave all the theoretical answers. And then he said that patient was taking proton pump inhibitors for 6 months, 7 months. I think most of us are culpable of this bloody mistake that we prescribe this anti-proton for months and years together. And there is no expiry date, like there is no expiry date for your marriage. And so we go on taking that, that's all. And one of the side effects is magnesium deficiency, and that causes, and you know, one of the important causes of prolonged QT syndrome is magnesium deficiency and calcium deficiency. Magnesium deficiency is the worst. And in ICUs, they give first magnesium when the QT is prolonged before they think of other methods. And sometimes they even do stellate ganglion block, etc. But mostly first magnesium. Now, I will not go into the other adverse effects of proton pump inhibitors. The gastroenterologist knows better. But he also knows it cannot be avoided, like corruption. Everybody has to take PPA has to be added to any prescription, cardiologist, neurologist, let him be any ology. Without that, there is no prescription at all anywhere in the world. Anyway, some drugs are harmless, and so we survive. Now that is Mark Twain. Cauliflower is nothing but cabbage after college education. He's a brilliant man. And look at the next sentence. It has always been my rule never to smoke when asleep and never to refrain when I am awake. Very good man. He obeys the doctor. Says, I don't smoke at all, sir. Yes, thank you. But he didn't ask him during sleep or wakefulness. Now, this slide is very important because neurologists should also know how to look at the blood smear. Morning I was telling you about sickle cell, and that's a sickle cell demonstrated to me by Dr. Vaithyalingam, cardiologist from Vellore. And once you find these hypersegmented polymorphs and a little large cells, that's a normal blood picture. I think all of us should be familiar with the normal ones, because exam, sometimes they will show this and we will make a wonderful diagnosis. That's why you should know what is normal. And this is abnormal, of course, with very big cells, macrocytosis, and segmented polymorph. This occurs in folate deficiency and B12 deficiency only, sometimes in chronic uremia. And then you must, if there is a neurology problem, you think of subacute combined regeneration. And you can, if you have got enough money, instead of looking at the blood smear, which is very cheap, you can do an MRI scan for 8,000 rupees and demonstrate he has got white signals in the posterior, the T2 weighted image. Posterior portion of the spinal cord is totally destroyed, and therefore it should be subacute combined regeneration. Very costly method of proving a simple diagnosis. And these are, of course, spiked RBCs in the peripheral smear in neuroacanthocytosis. It can occur also in people with A-beta lipoproteinemia, in which cholesterol is low, triglyceride is low, total cholesterol is low, HDL is low, everything is low here. And this is electron microscope, but that is a simple blood smear. And they get reversed by giving just vitamin E to the patient. They present with spinocerebellar ataxia. This is a case of portal systemic encephalopathy. Dr. Ramasubramanian showed hepatic failure plus encephalopathy due to portal hypertension. Hepatic encephalopathy is more fatal, and even without portal hypertension, because it kills you by other methods, is cerebral edema and intracranial pressure and so on. But this is portal systemic, in which hepatic function can be normal. They are not jaundiced, and they don't have any major problems in the hepatic liver function tests. This is a doctor from Thoothukudi. I saw him years ago. I don't know if he is alive or not, but I won't say his name. I think he is writing his name. You can, if you can't, you can read him. It's okay. That is his handwriting, which has become very bad. And he came for some mild tremors of the hands and unsteady gait and little urine albumin. Nephrologists did their best and did not find the cause. They said you go to neurology. So I examined him and I found that he has a gross cognitive dysfunction. Physically normal, well-dressed man with a good tie and on, with a cigarette in his hand, which doesn't smoke a full cigarette, has a bit of it and throw it off. And so very nice gentleman. And but he looked nice, but he was behaving very oddly, talking to wrong people and making wrong comments. And you can see here he throws Madras near the Delhi, which is an attempt by our Chief Minister also, very often going to Delhi, and throws Bombay into the sea along with the various gangsters there, murderers and swindlers who can run away with crores of money from the banks and so on. That's all Bombay into the sea. And he didn't know where was Chennai, and so he said, I'm sorry sir, I can't mark it. I said, throw Chennai, don't throw Chennai into China. I said, okay. That was his this is a very sensitive test for portal cystic encephalopathy, map drawing, because your spatial orientation is, and this is also 90% sensitive for portal cystic encephalopathy, 90%. Number drawing test, number connection. You draw like this, ask him to connect these numbers, they will be in chaos. And that's a highly sensitive electroencephalogram. That is normal electroencephalogram. You can see the mid-positive triphasic spikes here, triphasic complexes, periodic complexes, again highly diagnostic. In other words, you diagnose portal cystic encephalopathy by a very cheap test like this with a pencil and a paper in your consultation room. Your room is costlier, but the methods are cheaper. Now I will not go into the details. You have already, Dr. Subramanian has shown that. The milk mite grip, very interesting. Now, that's whenever you get these flapping tremors, when you ask them to grip your hand, they will squeeze and release it, squeeze and release it. That's a characteristic sign described in chorea, Sydenham's chorea or rheumatic chorea. But that also occurs in hepatic flaps. Flaps can occur in uremia, respiratory failure, etc., but also typical of hepatic failure. I will not go into it. Serum ammonia is always raised, and serum albumin is reduced, and usually they don't have any liver failure. Liver function tests are normal. They improve with oral diet restriction and labulose, etc. You don't need, and I'll show you further pictures. You can see this now. That's now in some patients when portal encephalopathy, you give flumenazole, they improve. See the EEG here. Very bad, very slow waves. Everywhere, 1 second instead of 8, 12 cycles, you get only 3 cycles. Cross slowing here, whereas that's 1 second distance. Here, after flumenazole intravenously, which you give for benzodiazepine poisoning or overdose, the EEG becomes normal, almost normal. So they thought hepatic portal encephalopathy must be due to some endogenous amines related to benzodiazepine. I mean, this is just a therapeutic guess, not a research guess. I don't know if it's true or not, but you can try flumanicil. I'll tell you, I don't know, Ramsubramanian is here. And then yes sir, I was presenting a case of repeated stupor and coma in London to international audience. You know, Dr. Arulraj, our clinical meeting should be like what they do in UK. Every 6 months they bring very difficult cases. The cases come before the doctor. They will be waiting outside. But there will be somebody who presents those cases with all investigations. Difficult cases, misdiagnosed or not diagnosed by in UK, United States, they all come. And then you find all investigations are there, the patient is there. And if you are a consultant who is attending the meeting, you must come 1 hour earlier. The door will be closed 1 hour earlier, not at the time of audience. And then you examine the case. You ask me I present the case. Ask me any investigation, I'll tell you, I give you. You make up your mind. Then attend the clinical meeting. Then you are a useful contributor to the meeting. Nowadays, people come after the meeting has started, and whatever mistake I present, they take it up and discuss. Not the patient's mistake, the presenter's mistake. That's what is happening in clinical meetings. It's very bad. Another place in our country where clinical meetings are superb, is Chandigarh, PGI. Every Wednesday, 8 a.m., the dean comes, all the professors come, physiotherapists come, anesthetists come, and the anatomists come, physiologists come, biochemists come. They are all there. So I can't say hypocalcemia. The anatomist says, sir, Dr. KS, can you tell me about the calcium metabolism? How do you say calcium is low? So we are in trouble. We should know physiology, anatomy, everything, because they are all sitting in the corner. Unless they are drowsy or drunk, they will ask you questions. And that's a clinical meeting in Chennai. I'm talking of 10 years ago. I don't know what's the stage now. Fantastic. So that you are really benefited by that meeting. Nowadays, our people come later on because they are cardiologists, they are neurologists, they talk whatever they want, get away. Without knowing calcium metabolism, how can I diagnose tetany? How do I know I have committed a mistake unless the biochemist is sitting and watching you? Because when I said sodium is low, how is it low? I said serum sodium is low. Oh, what is the total body sodium? What is sodium output? What is sodium? All sorts of questions they ask me. It's very difficult to present a case. Easier for the surgeon. They cut open is better. He's okay. That's here. Yes. These are the portal venograms I have done. These are two done by me 4 decades ago in Stanley in a liver clinic. And you find in those days we put the needle into the spleen and inject and look at the liver and so on. So it's such a big dilatation of the portal vein and the splenorenal vein, renal vein, they unite with the portal vein. And I think this is also another portal venogram. And this, of course, in portal cystic encephalopathy, these are very much dilated, but the liver may be normal. Liver may be normal or cirrhotic, but functionally normal and it's structurally abnormal. That's all our story. And then, of course, they have various methods of dealing with it. I will not go into it. But easily done by a physician. And one interesting thing, there is a patient with fever, undiagnosed in Chennai, all the medical colleges. And he came to us with a enlarged spleen. It was not malaria, it was not Kala-Azar, it was not Hodgkin's, nothing. I thought of portal hypertension. After I did this venogram, he developed spikes and chills, and I did a bone marrow. It was full of Leishman-Donovan bodies. It was a Kala-Azar case, diagnosed by me by a splenic puncture in the spleen. I did it for some other condition. I didn't make a diagnosis before the puncture. Yeah, wait a minute. I think you should know this. At Queen's Square again, I was presenting a case to, and Sheila Sherlock, top an authority on liver disease. Her book on liver disease was our Bible in our MD days. We used to read that. And she asked me to present that case to her. Repeated stupor and coma, admitted in the biggest London hospital, all investigations done. I give him steroids, he recovers and goes away. But gets readmitted again 3 weeks later. So we didn't know why he was getting this recurrent stupor and coma with all negative investigations. And at the time when Sheila Sherlock was asking me to present that case to her, I was just one of the people presenting. This fellow started scratching all over the body. This bloody fellow had never scratched his body because he was semi-conscious, unconscious all the time. I saw him. So doctor said, Dr. K.S., don't you guess the diagnosis? I said, what, madam? Why is he scratching? Is it bile salts? It is not jaundice. No, may not be jaundice. Maybe bile salts. It is hepatic. She was right. I did the portal venogram. It was portal encephalopathy. All of us missed on 3 admissions in one of the biggest London hospitals. I think scratching is due to bile salts, but I don't know how she diagnosed. This is clinical medicine, not investigation. This was the case of portal syndrome. Now, this is a very interesting picture. Look at this, please. Now, I teach that you must, all of us are taught in our undergraduate days. I'll tell you, MGR was admitted in the Rayapeta hospital before he became ADMK man. He was in the DMK at the time with wheezing. And the doctors there, he was all the time at least 60 years old. The doctors in the Rayapeta hospital gave him adrenaline for asthma. Asthma and hypertension, migraine are diseases of young people repeatedly. But you are telling when he is sleeping or looking at the cell phone, not when he is listening to you. So it doesn't reach his brain. For a chief minister, future chief minister, they give adrenaline at the age of 60 for asthma. And they then found out it was renal failure. We asked them to test the urine, test old people, asthma never. I think we teach the undergraduates some points, but I think we must emphasize it. And at the end of it, you must ask questions like what they ask New England General Medicine, whether they are listened to by some questions. Otherwise, you are teaching to a dead audience. Okay, now we can see here, we say palpate, auscultate. This is true for neurology, cardiology, nephrology, anything. You have to inspect, palpate, auscultate for everybody. Here we are some brilliant neurologists in Chennai. All of us were making rounds, all top people, I won't tell the names. A man was admitted with a headache, severe headache, and he had papilledema. So I said, I was presenting this case I have not examined the case, somebody else examined. Papilledema, sir, now, okay, do an angiogram because there is no localizing signs. We'll see where is the shift, so on. Then the barber comes at 1 o'clock. I call him. Navidan engi irundhalum varavonu announce பண்றேன். அவன் வரவே இல்லை. அப்புறம் எழுந்து போய் பார்த்தா லாரி கடியில் உட்காந்து சிகரெட் குடிச்சிட்டு ஸ்பிரிட் குடிச்சிட்டு இருக்கான் அவன் நாவிதன். அவனை கூப்பிட்டு வந்து எல்லாம் ஷேவ் பண்ண சொல்லி அவன் பாக்கெட்டில் சில்லறை போட்டு ஷேவ் பண்ணால் கொஞ்ச நாளைக்கு சார் இங்கே வாங்க போட்டேன். என்ன பண்ணேன், தலையில் பாருங்க சார் எவ்வளோ பெரிய பம்ப் இருக்குது அப்படின்னா. என்ன சார் இது மேலே ஷேவ் பண்ணிட்டோமா சார்னா. அந்த இடத்துல மெனிஞ்சியோமா. So he was diagnosed by a barber, missed by all MRCPs, MS, FRCS, grand rounds. This is called grand rounds, grand mistakes. Because none of us touch the patient. I trust Annamal Swami, he trusts our assistant, he trusts his house agent, and he trusts no one. And so we think everything is okay. You should never trust somebody who is not trustworthy. You can see here the big meningioma palpated by the barber, confirmed by further investigations, operated by highly qualified neurosurgeon. That's all that you have to ask you to do is palpate the skull. We are telling so many people, but which student does it? Cardiologist wants immediately echocardiogram, not palpation. Right ventricular heave எல்லாம் சொல்லி தரோம். யாராவது பார்க்குறாங்களா, பார்த்துருக்கீங்களா? பார்க்குறதே கிடையாது. நம்ம அதை வச்சு தான் ரைட் கேரோட்டிட் பல்ஸ்லாம் நம்ம பார்க்குறோம். வீனஸ்லாம் எந்த கார்டியாலஜி வீனஸ் பல்ஸ் பார்க்குறாங்க? ஒன்றும் கிடையாது. அது மாதிரி எனிவே ஐ திங்க் தே ஆர் மோர் தேன் கார்டியாலஜி, பட் வி ஆர் அண்டர் கார்டியாலஜி. தே ஆர் சூப்பர் கார்டியாலஜி. Now this is a warm skull of Paget's disease. All that you have to do is to touch him and you make a diagnosis. You don't spend money. Touch him, it's so warm. It has to be osteomyelitis or Paget's disease. If it's diffuse, you call it Paget's. If it's localized, you call it osteomyelitis. Very simple. And this patient failed many MD candidates, including several Vellore candidates. They all appeared. I was a supervisor witnessing all this catastrophe because he had a hemiplegia and he had dysphasia. The interpreter was no good. Somebody unrelated interpreter, so he didn't know. All of them examined him and discussed various causes of hemiplegia brilliantly. But none of them said the correct diagnosis because they didn't touch him. They discussed about cardiac embolus, they discussed about uncommon conditions in young place, APLA syndromes, all sorts of things. because he had a fracture, a depressed fracture here, and he was not able to tell this to the candidates, and nobody touched him. So they failed in the exam. He failed many candidates. Because I say, if you can't do these simple things, inspection, palpation, percussion, and I think you deserve failure, because we are saving your future today. Anyway, we can pass our other reasons. So inspection, palpation, and then next one. This one. This case was discussed in Chennai by a British neurologist invited by us to give lectures as motor neuron disease, because he was not able to pull out the tongue, it was wasted, and it was also fibrillating. And after he went away, I auscultated him as a routine only for taking the blood pressure, neck veins, and so on. I found a loud bruit. Then I sent him to CMC Vellore. They did an angiogram and found a AV malformation, which was misdiagnosed as motor neuron disease. Because we didn't auscultate for a bruit. We say auscultate for a bruit every case. I'm telling you routine investigation, not very intelligent investigation. Routine undergraduate investigations. And in Madurai, I have seen at least 6 cases of difficulty in speaking, restricted movement of the tongue, diabetes, hypertension, which is our birthright by the age of 50 or 60. Every patient will have diabetes, hypertension. Diagnosed by top neurologists in Chennai and Madurai as vertebral stroke or something, because the CT scan always obliges by a few lesions, and MRI always improves by seeing more lesions to improve our mistakes. I only touched the tongue. It was carcinoma tongue in a diabetic and hypertensive at the age of 60. And no neurologist touches the tongue. Find out your neurologist. No cardiologist also will touch the patient nowadays. It's a trouble. I am telling you all this. I am not criticizing anybody, but I am protecting all the doctors and the patients by this, because we must touch the. You have a paper handkerchief in your bag which can be thrown away. All that you have to do, then clean your hands. Nowadays with antiseptic lotion for corona. Previous days just wipe it off, that's enough. And they are missed. Carcinoma tongue is missed. And they are all proved later on by surgeon, by biopsies and so on. I am just saying palpation and percussion and auscultation for bruit and for warmth and so on. I think that will be the last slide. Is it? Sorry. Okay. Next. Simple X-rays, tuberous sclerosis, craniostenosis, Crouzon's disease, craniofacial dysostosis. This is pure craniostenosis. Severe intracranial tension, beaten silver appearance, but without enlargement of the skull. They can come with you defective vision and so on. You don't need costly investigation for this. Final, I think this is final slide. Sorry, sir. Madam. Very important. You can answer this. So, why are you wearing dress? This is a question asked by a dog and the monkey. I don't wear a dress. See that? Now, why did I put Shah Rukh Khan's photo and Vidya Balan? Very famous people in our country. They are ambassadors for toilets in India. Ambassadors for toilets appointed by the Government of India, New Delhi. So in Madurai, some toilets have their photographs. Shah Rukh Khan and Vidya Balan. Because they want us to stop passing motion and urine in the public. Make it private in a latrine, but not public or visible or outside. And then you find here, pet dogs get our love, and we like dogs and monkeys for experiments, and dogs for domestic pleasure and so on, reducing our stress. And the questions that they ask is, we don't wear any dress in summer. Even in summer, why are you wearing so much dress? So Dr. Vidya Balan obliged us by a posterior approach and showing that she has no dress posteriorly. So at least partially helpless. This man doesn't help us at all. That's the purpose of this picture. I think we'll stop with that. Just one more, sorry. Now about yoga, because I am living in a country which advises yoga, and Modi Prime Minister may get angry if I say yoga is bad. I don't say that, but yoga is not profitable for human physiology, because you see this picture neurologically. If you do cycling for half an hour a day for 1 month, your brain improves like this. Your hippocampus enlarges, stem cells are activated, memory improves, brain circuits improves. These are all done by hundreds of cases in some other country. Whereas when you do yoga, it shrinks, hippocampus shrinks. It's good for you, because if a hippocampus is not there, this lady calls me an idiot, I will say thank you. If your brain is shrunk, I will say thank you whenever when she pushes me out, I will say thank you. That's yoga. But benefits of yoga is it reduces your blood pressure, reduces your pulse, reduces your anger, improves your behavior, makes you quiet, reduces your ego. There are so many blah 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 such as minus points, but I am talking neurologically. Your hippocampus improves only by cycling, not yoga. And this is just a small point. I should not say this. I say yoga is good, but cycling is better. It improves Parkinson's. In United Kingdom, USA now, people with Parkinson's, dementia are asked to dance with available girls and cycle, and of course swim if they're possible. And in Europe, they are doing electronic gadgets to make you swim even if you are paralyzed. They attach the gadgets, computers, and so on. Thank you very much.
Thank you, sir, for that wonderful presentation. Especially, it fits into the cart before the horse. The cart is full of investigations, and the horse is only pushing the cart, when we actually ought to pull the car, have the cart behind the horse. Thank you, really, illustrations were just wonderful. I now hand over to the organizer.
We have now come to the end of our scientific session. As we are running short of time, delegates can interact with our professor during lunch. We'll have a short valedictory function. We welcome our professor sir, Dr. Annamalai Sami sir, Arulraj sir, and Dr. Selvaraj sir onto the dais.
Teachers and the chief guest, everybody. How long myself and Arulraj are doing this academic activities, especially for this teaching program. Hereafter, youngsters must come forward to do this. But of course, we will help you to do this. So we are doing this for the last 3 decades in this town. So you must all come forward. Juniors must take the responsibility of, as Professor said, spread the clinical medicine, message of clinical medicine, so that your future generation will be benefited. Any comments from the audience? Welcome.
So thank you, sir. Very nice. So very nice program organized by Dr. Arulraj sir and Selvaraj sir. As Dr. Selvaraj sir told, so youngsters should come forward. Because in many meetings, only old people are attending, even in IMA or AP meeting.
I like to defend. I was doing it. Now Selvaraj is doing it, I am supporting. Now we are doing it.
Yes, Subramania, now we have
to develop the youth.
Yes, sir. Like that, so youngsters should attend. Thanks, sir.
Ram Subramaniam, we like to hear your comments.
Sir, actually, right from the beginning, I am also part of your team only, sir. I have been doing it a lot of work when I was in the medical college. Now I wanted to tell everybody here, sir, next year I'm taking over as the president of Tamil Nadu ISD. So we are supposed to have a meeting here in Tuticorin.
Your taking over takes place in Tuticorin or Chennai?
Sir, March is supposed to take, but because of Corona, it's become a virtual meeting. So I've asked them that next March, I'll conduct the meeting here. And in between, definitely I'll be conducting some midterm conferences.
Please. Yeah, Padmanabhan, your comments. Rajan inga manapla. Kudunga.
So really it was so fantastic, sir. Unless we assemble like this, very difficult to hear the experienced doctors, advisors, and a lot of practical points. Definitely it will be very useful for us to dealing with nowadays cases. Thank you, sir.
Postgraduates have some ideas? Postgraduates.
Situation. So we are going to conduct the TAPICAN 2021 in Tirunelveli in August.
Situation will definitely improve. We will have.
As the government should...
In this COVID pandemic, this is the second API meeting we are having.
Sir, we are also conducting, but limited members. But government will not allow a large gathering. That's why. Only they are allowing now 100 people only.
We'll hope things will improve.
That's why it's
Like 100 people who will sit in the hall. We will have it.
Postgraduates. On the segment kundu kudu.
Lunch will be served, don't worry.
Yaar pesringa? Who wants to speak? All of you want to speak? Ankita, you can give your voice.
Thank you, sir, Dr. Srinivasan, sir, for coming. We all learn by mistakes, and it's better if we learn from others' mistakes. Today you presented so many cases of people who have missed the diagnosis and simple tests you were teaching us. So it was very valuable for us. Thank you for coming, sir. And hopefully we'll have such meetings more after this COVID pandemic gets over. Thank you.
And let me tell you one thing. In Annam University, I used to take doctors from Madurai Apollo, 25 of them, or Madurai Medical College, and we will address 500 students, many various CMP programs. But at the end of it, we'll give them all paper, pencil, or whatever it is, ask them to comment about the speakers. Really. And I tell you, Dr. Samsi Bose, who's a professor of plastic surgery in Madurai, I think all of us know, absolutely straightforward man, down to earth. And he asked one student, your sister has just burnt her with a matchstick, what shall we do? That's how he makes you think and wake up without looking at your cell phone. So you have to think, your sister is burnt now, what will you do? It's burning. And then you don't answer. Then he says, who is your teacher? Professor of plastic surgery is sitting on the chair as a chairman. Your boy is not answering. Why don't you answer? He has to answer. It's very lively because nobody can sleep. It's very lively, it's straightforward. That's how it is. And then he gave a lecture on some subject. And then there was a professor of anesthesia who gave a lecture on brain and pain relief. And he was looking at the slides and writing something in the board, never looked back. Very devoted to his lecture. So the student said, the learned professor of anesthesia should occasionally look backwards to see whether there is any audience. The boards are all akinetic and inanimate. They won't move. But the audience is not. That's what is written. And then a cardiologist, cardiac surgeon, described very nicely how cardiac surgery developed from so many decades ago and how it has progressed so nicely. Beautiful lecture on cardiac surgery, modern cardiac surgery, and the way they puncture holes and connect blood vessels to treat angina pectoris. All sorts of latest things he was saying. Again, one student wrote, sir, we are all tired after heavy classes by our senior experts. They are written there. Your topic was very good. Your cardiac surgery was slow to develop. You are even much slower to tell them. Very interesting comments from students because they comment on us, isn't it? And it's better for you to know what their comments are so that next time we improve. As I told her yesterday, in the last conference, I have attended several meetings in Thoothukudi, but now I am comfortable. You are also comfortable. But Arulra used to punish us in those days by giving it Kalyana Mandapams and other places, taking off your shirt to attend. Now he wants you to come in suit. Otherwise you'll be sweating and fuming with a lot of blocks in between. You can't look at the slides. He has conducted many meetings in inappropriate circumstances with appropriate people. But that doesn't matter. So I think the audience views are very important to improve the speakers. Otherwise we will never know our mistakes, isn't it?
There is a neurology postgraduate, DM. You want to listen from? Give the mic to her. Yeah. The presentation was very good.
Thank you, sir. So thank you for giving a wonderful opportunity to present in front of those eminent teachers. And we have shared a wonderful 4 to 5 hours of knowledge, and we have hope to attend such meetings in the future also, sir.
What is your learning from Professor K.S.? Because more than all of us, you will be the first line beneficiary.
Yes, sir.
That's why I am asking.
So the Association of Neurology with Clinical Medicine has been wonderfully taught by him by various giving various examples of cases diagnosed by him. So we have.
He has done this job. At this age, he has come all the way. And
Yes, sir.
he was with us whole evening yesterday. Today also he is here.
So to teach us the budding doctors who will learn from him by his mistakes and by others' mistakes, and we will gain confidence in treating patients better by improving our knowledge.
And the main message is our teaching comes maximum not from teachers, not from internet, not from books, not from films. It comes from the patient. He teaches you more than anybody else. But you must be with the patient and be patient. To listen to your teacher, who should be patient with the administration. And that's how we all get better. Internet gives, and about internet I'll tell you. What is internet? It's connecting two computers. Connecting two computers. If both the computers are uselessly fed by some articles which are not really approved, then you are having a wrong knowledge. Many brilliant people in the whole world do not come. In fact, I have given lectures in France and Germany and all. Many of this work is not published in English literature. And it doesn't come in the internet at all. They said, why should we tell others? Why not they come and learn from us? Why don't you learn French? Why should I type into English? That's what a French neurologist tells me. This is happening all over the world. So internet is not all and all. It is only a small portion of knowledge, but wide portion of knowledge. And if you read in the internet whatever we discussed today, mortality will be very high. They will frighten you with unusual cases and abnormal cases. You forget the common causes. The other problem about internet, because you're all internet oriented, I know, is that you must read the whole article. Don't read the summary. They will never give they say the truth but not the whole truth. We promise we say the truth, whole truth, nothing but the truth, but we don't do the later too. We only say some truth and hiding the other truth. I'll tell you one example. For asymptomatic carotid stenosis, I have worked with the top neurology experts from Barnett from Canada, and I was in the committee of ICMR on stroke and so on, international audience and all. And his view is that in carotid stenosis, if it is more than 75%, and if he has had one stroke earlier and has recovered, he should be having an endarterectomy done or a stent, depending on that. No other, it should be more than 75% stenosis. He must have had a reversible stroke. That means this may produce another stroke, so they want to do it. And the number needed to treat only is 1:5 or 1:4. The number needed to protect one from heart attack by giving clopidogrel is 30. 28 people don't benefit. But this number needed to treat one diabetic is 1. One hypertensive is 1. You can't say two people take a drug, one fellow gets better, another fellow does not get better. The drug is useless. So, but in the internet, what happens? So the problem is about asymptomatic carotid stenosis. There is a stenosis in the left carotid artery, 50%. He has no symptom. But the surgeon wants to operate because he says, I will prevent a stroke tomorrow. He doesn't believe in that. It has not produced a stroke today. Why did you think it will produce a stroke tomorrow? You don't do it. But this has produced a stroke. So it means the plaques or morphology is bad. It's friable. It may anytime get dislodged. So, and for that, 500 people have to attend the meeting who have, the doctors should have done 500 carotid endoscopies and 500 controls. Then only they can enter his room. So much is being done. So for the asymptomatic, there is a controversy. All of us believe you should not do anything about it. Just give them drugs. But they publish in internet that it must be operated to prevent future strokes. And when you read the article, 10 of the people, in hundreds of them who have done asymptomatic stenosis, they have developed stroke, but in the opposite territory. So they concluded that they prevented a stroke in this territory, but they didn't prevent strokes altogether. In other words, they have operated on the wrong side. Stroke occurred this side. What is the use of operating on this carotid?
Story is, see the patient whole, fully. Don't segment it to subsegments and don't put it to systems. See the patient as a whole. What Professor K.S. has conveyed to us is, science is there, which we are taught, we are learning how to apply it on the patient. See the patient as a whole. There is a stroke which has come. Simple examination of the pulse in all the vessels will give you the etiology. The symptom is different, sign is different, etiology is different. Based on that only further diagnosis. And you can go up to the PET scan to make a diagnosis. Simply checking his pulse. That's what has been proved here, and he has proved by all the examples here. We should be always conscious, alert, and clinically oriented. On that you add, science. We are all, on behalf of Tuticorin API, and on behalf of all the faculties who have cooperated and joined us, and the youth who have been benefited, I offer our profuse thanks to our Professor K.S. and we will see that we want to see him for many more years for our knowledge upgradation, which God will definitely support our request. Sir, anything? Sir, Professor Annam Sani wants to say something. Sir.
One we have to say something, one whom we asked to say something.
As you said, the younger generation, if given a chance, definitely they will do a better job. Yes. Only thing is, you don't give them a chance. Every time, you organize an event, some important heads of the departments are roped in. You be the chairman, you be the secretary, you be the treasurer, etc. And you don't trust the younger generation. You give them a chance. We have tried a few times. They do a better job, no doubt, because they have put all heart inside it. And that is one. So that is regarding the future management of meetings. Second thing, as you said, no book can give what Dr. K.S. has given. It is all, each and everything from studying the patient as a whole. See, they used to say, don't treat the sphygmomanometer, treat the patient. The figure is not the thing, it's the actual patient as a whole. So that is the approach he has stressed. I am sure the younger generation will take it and benefit it, and not only for them, for the patients also. So thank you.